is Dr. William Tseng. We're so excited to have him today. He is a surgical oncologist with an academic practice dedicated only to the treatment of soft tissue sarcoma. He sees adult patients and operates on sarcoma throughout the body, including the extremities, trunk, and retroperitoneal. He's a strong supporter of personalized and, when needed, multidisciplinary care for sarcoma patients. And he's recognized specifically for his expertise in liposarcoma and retroperitoneal sarcoma. So welcome, Dr. Tseng. I'll let you take it away.
Can you guys all see my screen now?
Yes.
Okay, sorry.
Yep, we can see you and hear you.
Okay, great. And okay, great. Yeah, well, thank you for the introduction. It's great to be here this morning. I'm going to be talking about the surgical treatment of soft tissue sarcoma and quality of life. As Alyssa mentioned, I'm a surgical oncologist or cancer surgeon at USC in Los Angeles. And I just wanted to emphasize that I'm very dedicated to sarcoma, and that's all that I see and treat. Just to start off, I know it's been a crazy year for all of us. I'm very excited to see everybody here on a weekend, on a Sunday morning, here to talk about sarcoma, to learn about sarcoma. But I do hope that you guys do have a chance to relax and have some time to yourself. So anyways, I wish everybody the best. My disclosures, I don't have any financial disclosures or financial disclosures to pharmaceutical companies. I do get a small stipend from Up to Date for writing the chapter and updating the chapter on retroperitoneal sarcoma. Some of my non-paid disclosures, I'm very happy to say that I've been part of the medical advisory board for Sarcoma Alliance for the past a few years, I think 2 or 3 years, if I remember correctly. And then I'm very excited to be part of the board of directors officially as of the last week or so. So just to start off, to get everybody on the same page, what is soft tissue sarcoma? I won't spend too much detail on this because I know the other speakers have covered this in detail. But what is soft tissue sarcoma? Soft tissue sarcoma is, of course, a cancer, but it is very rare. I wanted to emphasize that. It's 1% of all cancers in adults. This accounts for approximately 12,000 to probably 15,000 cases per year. And this is in comparison to other more common cancers, such as breast cancer. In that disease, we see over 250,000 cases per year. So it kind of gives you an idea of how rare this disease is. It can occur anywhere in the body, and that means in the extremities or arms and legs or limbs. It can occur in the trunk or the body wall. That's the abdominal body wall or the chest wall. And it can also occur in the retroperitoneum, which is the back of the abdomen. We'll have some slides just dedicated to that. And I think a very important point about soft tissue sarcoma is that it's very heterogeneous. There are many different subtypes. There are at least 50 to 70 different subtypes that have been described and that we know about. This little diagram here, I apologize about the small font, but this is trying to show the different, some of the different subtypes of soft tissue sarcoma on the left-hand side. and some of the very unique clinical behavior in terms of where they spread, do they not spread, do they spread, just unique clinical features that are very specific to each of those subtypes that are listed. In 2016, for an editorial to the Annals of Surgical Oncology, I did come up with this analogy of wine that I use with my patients often to help understand soft tissue sarcoma. And my disclaimer with that is to be perfectly honest, I really don't know much about wine myself. I don't really drink wine. But anyways, the analogy is that sarcoma, because of the many different subtypes, it's a little bit like wine in the sense that there are nuances to each of the different subtypes that are important to recognize, just like there are nuances and little subtleties in wine. So I often say a red wine from France, from the northern part of France, is different from the southern part of France. So you kind of get the picture. So the analogy is that sarcoma is a little bit like wine. And I do actually credit one of my own patients. She had leiomyosarcoma treated and is doing well. She actually inspired this analogy, and she is a wine connoisseur. So this next slide, treatment is a team effort. And I think this is a very important slide. If you guys don't get anything else from the other slides, this is probably the most important slide. And that's just to emphasize that although surgery is a very important part of the treatment of soft tissue sarcoma, it's not the only part. And oftentimes patients do benefit from receiving other therapies, chemotherapy, radiation therapy, which I won't go into that much detail in this talk. But as I said, sometimes it does benefit patients to receive those, not always. What's probably the most important and the cornerstone, I'd say, of treatment of soft tissue sarcoma is what's pictured here, which is a multidisciplinary tumor board. And what that really means is it's a group of physicians who specialize, in this case in sarcoma, a group of physicians who get together on a regular basis, usually it's on a weekly basis, to discuss each individual patient's case, to say that to have a radiologist go over the imaging, the CT scan, the MRI, to have a pathologist go over the slides, the histology to make sure it's the correct subtype, and then to have a medical oncologist, a radiation oncologist, a surgical oncologist present to discuss whether each of those therapies is important and may benefit that patient or not. So again, treatment is a very team effort, very collaborative effort, and that's exemplified by this multidisciplinary tumor board. So surgery is the main treatment for localized disease, the disease that has not spread to other organs. I'd like to say that compared to other cancers, one of the very unique things about sarcoma surgery is that it's very much a balance between the surgical technique and the technical part of the operation, meaning like what you do at surgery in terms of getting out the tumor, how you treat the adjacent organs and structures. But it's a balance of that and the biology of the disease. What I mean by biology of the disease is the understanding of the disease and how it behaves. And that's independent of the surgical technique. And as a very vivid example of this is that wine analogy that I said, understanding the different subtypes and how they behave. What do we expect for example, a well-differentiated liposarcoma to do independent of the surgery, as opposed to, say, a dedifferentiated liposarcoma or a myxoid liposarcoma. So that understanding of the biology or the disease behavior is very important, even for the surgical treatment of the sarcoma. So in terms of surgery for sarcoma, the way I like to look at it and the way I want you guys to kind of think about it is that it's kind of two different categories. There's sarcomas that occur in the extremity and the trunk, and then in the retroperitoneal. The surgical approach is different for those two body locations. So if we look at extremity and trunk, probably about, I'd say 10 years ago, maybe 20 years ago, the standard of care was amputation. This diagram here is showing a below knee amputation. The one next to it is an above knee amputation. The current treatment of extremity soft tissue sarcoma, limb salvage, is the standard of care. What limb salvage really means is it means it's an optimal, a patient should have an optimal cancer operation by somebody who is experienced in treating this disease, and in this case, the sarcoma, of course. And then oftentimes it does involve radiation. I put plus minus because there are situations when you have a small tumor, a low-grade tumor, where you may not need radiation if you can get a very wide resection. But oftentimes, and often more often than not, the radiation is an important part of limb salvage. Part of limb salvage, in addition to keeping the leg or the arm, is function preservation. That means you keep the leg and or the arm, but you also have good function of it. And then I also want to emphasize that with limb salvage, more and more we use the resources and the help, the collaboration from our plastic surgery colleagues. So this is an important part of limb salvage, I'd say, as well. So one of the questions that often comes up is margins, and what margins really means is it's the amount of, or it's not an amount, excuse me that I said that, it's more tissue, normal healthy tissue around the tumor that the surgeon removes. And so in many cancers, this is very important. In sarcoma, this is also very important. And specifically for soft tissue sarcoma, the extremities, this is still important to get negative margins. That means that when the tumor is removed with the healthy tissue around it, that the pathologist examines it and then determines that the edges of the healthy tissue are in fact negative. They don't have any sarcoma cancer cells inside. So it is important to get negative margins in extremity and soft tissue sarcoma. However, this does depend on the histologic subtype. That's that wine analogy again. And it also depends on the tissue barriers. So that's things like fascia. Fascia is a thick fibrous covering that in the extremities you often see that, you do see that on muscle. And so the picture on the right-hand side, what that's trying to show is that fascia can be a very thin layer. So it can literally be a millimeter in thickness. But if you do take that fascia, that is considered an adequate barrier for the tumor, even though it's a millimeter or 2 millimeters in thickness. So the point with that is that you don't need to necessarily have a huge 2 to 3 centimeter, or certainly not a 5 centimeter margin of healthy tissue. It also depends on adjacent critical structures. So if you have a blood vessel or a nerve that's right up against the tumor, the question is, do you remove that and compromise function for negative margins? Well, the answer is really no. You try to preserve those as much as possible. You try to use radiation therapy to try to get at the microscopic disease, the positive margins that you'll probably have along the edges of those vessels, all to try to preserve function. So that was extremity and trunk. Now, when we look at surgery for the retroperitoneum, sarcomas in the retroperitoneum, I'd like to say that this is a very different beast. To get everybody on the same page, the retroperitoneum refers to the back of the abdomen. This is a diagram from my up-to-date chapter of the back of the abdomen, and you could see major blood vessels there, the inferior vena cava, the aorta. And I think a simple way to think about it is that this is the area right next to the kidneys. And this is the area where patients can develop sarcomas that, as I'm trying to show here, they can actually be quite large, and they can be touching up against, if not invading, a lot of these important structures. And this is an example from surgery. I apologize if this is too graphic for some of the audience, but this is a picture of a patient's abdomen open at the time of surgery. You could see that's the level of the heart at the left-hand side of the screen. This is the bladder at the right-hand side of the screen. So you can see it's a very large tumor, and embedded within that tumor, sitting on top of the tumor, is actually the patient's left colon. And then I would kind of challenge you to think about when we talked about margins for the extremity soft tissue sarcomas, because of the proximity of all of these important critical organs and structures. I would challenge you to kind of think about what kind of margins do we need to achieve in this situation. So for retroperitoneal sarcoma in the United States, this is at major sarcoma centers around the country. The standard resection that we perform is complete tumor removal. That's pretty obvious. And the general principle is that these adjacent organs and structures, these critical organs and structures like the kidney, like the blood vessels, these are removed if they're involved. If there's obvious evidence of involvement, we cannot separate the tumor in a safe way from let's say the major blood vessel, or we would have to leave some tumor behind. We do remove those organs in those situations. That's in the United States. So what this really entails is that this is not a laparoscopic operation. It's an open operation. In fact, I would argue this is a little bit my opinion, but it's not just my own opinion. It's the opinion of other sarcoma surgeons.
I went to Rochdale this weekend. I had a
if you have a surgeon that proposes a laparoscopic operation, I would say that that's not quite ideal. Let's just put it that way. These are open operations. In approximately 50% of patients, the tumor does get removed with one kidney. That's the kidney on the side of the tumor. And in 50% of patients, part of the colon on the side of the tumor, again, does get removed with the tumor. But I do want to emphasize that these operations can be much more. These resections, again, this is standard resection in the United States. They can be much more involved, big operation. These are big operations. And I do think it is important. We talked about multidisciplinary care for just sarcoma in general with the tumor boards. Well, oftentimes we do find that we have multidisciplinary surgical teams, at least in my practice at USC. We get together with, so not just my team, where I lead the operation, but oftentimes we use the resources and the collaboration of the vascular surgeons, sometimes the hepatobiliary surgeons, pancreas liver surgeons. Anesthesia is a very important part of these big operations, and then communication even with the ICU team. Sometimes these very big operations patients do require recovery in the ICU initially. So I just wanted to mention very briefly about margins, getting back to that question that I posed to you guys earlier. So in retroperitoneal sarcoma, what we were just talking about, that's standard resection. In Europe, specifically advocates from Italy and France, there is a concept called extended resection or compartmental resection. In fact, I think this was one of the questions in the Q&A session from yesterday that I typed an answer to. This is the concept of removing the tumor completely, which everybody agrees, the United States or in Europe. But the concept of extended compartmental resection means that you remove the adjacent organs and structures, even if they're not obviously involved. Even if that kidney is just touching up against the edge of the tumor, that gets removed. The whole idea with this is that you want to try to get as much normal, healthy tissue around the tumor out as possible to essentially get negative margins. And that, unfortunately, just because of the location of the tumor, that normal, healthy tissue means kidney, potentially blood vessel, certainly if it's muscle or if it's something that you can take without much consequence, that's all part of extended resection. We could dedicate an entire lecture just about this, and I didn't want to spend too much time about it, but that's the concept. Ultimately, we do have agreement across the Atlantic Ocean between US and Europe, and that's that it does really depend on the individual patient's situation, and it depends on the histology, biologic factors, disease behavior factors. So it goes back to my wine analogy for sarcoma in this situation. So one thing I wanted to emphasize for both retroperitoneal and extremity soft tissue sarcoma is with this question, are outcomes better with a specialist, a sarcoma specialist? And the answer is a yes. That's 2 exclamation points, capitalization, bold letters, yes. I'd say the most robust data that we have to support this was published just recently in 2019, last year. And this was almost 36,000 patients in France that looked at this question by looking at outcomes of patients treated at sarcoma centers within France versus outside of sarcoma centers. And the outcome is that the patients do much better when they're treated at sarcoma centers. We took this a step further. Sylvie Bonvalot in the bottom right-hand corner is a sarcoma surgeon in Paris, and along with myself and other colleagues, Rafe Pollock at Ohio State, Alessandro Granchi in Milan in Italy, we put together this that came out in 2020, just before this whole COVID pandemic. And this is it goes on, it expands on that wine analogy that I published in 2016, but it also provides what we think, this is our opinion, but what we think is a definition of a sarcoma specialist. It's a little biased towards surgical oncology to say that these are sarcoma surgical oncology criteria. So I apologize a little bit about that. It doesn't really apply as much to medical oncologists or radiation oncologists. So in the last few minutes, and I apologize, I'm running a little bit over time, but I did want to address quality of life. We talked about this. I think it's also important to be able to enjoy the wine, so to speak. So for the patient with soft tissue sarcoma, and my disclaimer with this is even though I see this disease, I treat this disease on a daily basis, I really don't know what it feels like to be on the other side. But at least this is what I can see, and this is what I see in my own patients. But for the patient with soft tissue sarcoma, this is a very, very rare disease. Most physicians, most treating physicians, most local physicians don't know much about it. Because of the many different subtypes, it can be very confusing. So for the patient, I think there's a lot of misinformation. If you were to type in sarcoma, if you were to Google that, you would find a lot of information. Whether some of that is good or bad, it's up for discussion. For patients, it can often be a very subtle presentation. It can be a very painless, a completely painless mass, or even no symptoms at all. A patient can find out that they have a CT scan, or they can find out that they have a sarcoma when they have a CT scan done for a completely unrelated reason. And oftentimes these are large tumors. So for patients, I think this is very scary. Sarcomas can be very aggressive. And overall, because of all these things, sarcoma is very life-changing. So because sarcoma can be aggressive, I definitely think we need to be very aggressive on the treatment side. But it's also important to consider quality of life. And I just wanted to address a couple of things. One is the word cure. I do want to say that unfortunately, the reality is that, I wish I didn't have to say this, but the reality is that we do not have a great cure for sarcoma, for most types of sarcoma. Having said that, though, it is something that, again, we continue to be aggressive with, and that for most patients, I think the way to look at it is, well, it's not so much cure, but it's more that it can potentially be a long-term, kind of long-standing condition. You can treat the patient, you can do surgery, get the tumor out, you try to do drug therapy, you try to do radiation therapy, and it doesn't come back, but or the patient does well, but 2 to 3 years later, it may still come back and then require further treatment, but the patient is still alive. So this concept of cure, in some cases, in many patients, it may be more of a long-standing disease may come back, patient's still alive, but we continue to treat it aggressively. The other concept that I just wanted to address just very, very briefly is the word palliative. So palliative for, I think a lot of doctors, maybe a lot of patients, when they hear that word, palliative means end of life. It means hospice. It means that's pretty much it. For me, palliative, as a surgeon, as a surgical oncologist, I use that term palliative to say symptoms. So when I refer to a palliative operation, that does not mean that the patient is going to die. The patient may be dying, but it doesn't mean that the intent of that palliative operation is to treat symptoms, symptoms to improve the quality of life. So when we look at quality of life for the extremity and soft tissue sarcomas after surgery, we talked about limb salvage. Limb salvage includes surgery, includes radiation. So the different scenarios, you can have radiation before surgery, or you can have radiation after surgery. Well, we know that radiation before surgery causes higher wound complications. Radiation after surgery actually causes lower wound complications, but has more what we describe as fibrosis. That seems like it's kind of vague. We're not really, what is really fibrosis? And what fibrosis really means is lower quality of life. It means that if you give radiation to that patient after surgery and the tumor is right next to the knee joint or the ankle joint, the patient has a lot of stiffness and it impairs their quality of life. Well, there are many studies looking at quality of life in sarcoma. I just wanted to highlight a very recent study, just came out a few months ago from Germany, 182 patients. It's a study over 10 years, looking at patients over 10 years. And indeed, there are important quality of life issues, and there's differences between patients that have surgery alone versus radiation plus surgery. You can see the different quality of life measures, the quality of life scores, and there are clear differences across different measures of quality of life. And then I just wanted to highlight very quickly an example of a patient. This is an 86-year-old who had a very aggressive sarcoma of the right upper arm, 83-year-old. And you could see in the end, despite all the discussion about should we do limb salvage, should we try to preserve, his hand and his wrist and everything was actually very functional. But just the extent of surgery, the extent of reconstruction that would be needed, the recovery for this 83-year-old. After many clinic visits, much discussion, we ended up doing an amputation. The patient, and this is what he looks like under the shirt. And he even told me that sometimes amputation is better. So it is a very personalized, individualized decision. So when we look at retroperitoneal sarcoma after surgery, quality of life, this is really not that well studied yet. And this is definitely an area that within retroperitoneal sarcoma, we need to study much more. This is a recent study. It's actually from Asia, one of maybe 2 or 3 studies, I'd say, that have looked at this issue. The concept of standard resection versus extended resection that I brought up earlier, what's done in the US versus in Europe, this is ultimately, it does kind of become a quality of life issue, because what it really means is that with standard resection, retroperitoneal sarcoma, patients can have this amount of recovery there in blue. The disease may come back. The patient may need another resection. Whereas in Europe, with an extended resection, they may have a longer recovery because it's a bigger operation. And the disease still does come back, but it takes a longer period of time to come back. And the patient needs maybe 1 surgery as opposed to 2 surgeries. In the end, patients in both situations are NED, no evidence of disease at 10 years. But it also comes down, it brings up that question, which patient, the US patient, the European patient, has better quality of life. And finally, and I do think this is my last slide, I really apologize about going late. going over time. Quality of life for all patients after surgery. There are other considerations, and I would say these are things that you don't tell the doctor, that don't come up at the clinic visit for whatever reason. That impacts quality of life. I think for patients that are young, the adolescents, the young adults, sarcoma and surgery for sarcoma brings in unique issues in terms of quality of life. There's also unique issues, other considerations that are cultural. I believe Dr. Benjamin, or one of the medical oncologists yesterday, even brought up that word chemo. I know for a lot of cultures, in Los Angeles here, we get many different cultures. That word chemo has very strong implications. And chemo is only one of many treatments, systemic treatments that are available. Socioeconomic, financial considerations. And finally, once you've done surgery for the patient, you've removed all the disease, surveillance is very important. Surveillance meaning getting CT scans or MRIs to look for any evidence of disease coming back. And it's that doing these scans that from what my patients tell me, it does cause a lot of scanxiety. This is especially the case for retroperitoneal liposarcoma. So with that, again, I apologize for going over time, but I thank everybody for your time and attention. This is my team at USC. You could see that it definitely takes a village, not only to raise my 3-year-old, who's pictured right there in the center, but it takes a village, so to speak, to treat this disease in the proper way, in the adequate way. And that's my contact information. My coordinator is Ashley. I do also have a Facebook page meant to be educational on liposarcoma. And then I also have an Instagram page that is also meant to be educational. You can feel free to follow me at either or both. Thank you again.
Great.
Great. And Dr. Tseng, thank you so much. I didn't mention during your introduction that Dr. Tseng is our newest board member. So welcome, welcome. This will not be the last time that you all hear from him, and we're so excited to have him on our board. We do have a number of question and answers here. Let's see.
So I think this one here, is staging laparoscopy with exploratory laparotomy different from open surgery? If yes, how?
Yes, the answer is yes. It's different. Staging laparoscopy means it's minimally invasive surgery. So it's looking into the abdomen through small incisions, just kind of like how a gallbladder would be taken out. And so the answer is yes. Whether it's important to do a staging laparoscopy, usually not. It doesn't hurt, I would say, but it's usually not done. Usually CT scan is adequate to get an idea of the tumor, to get an idea of the extent of the tumor. And the only thing with staging laparoscopy is if the surgeon ends up trying to remove part of the tumor or tries to cut into the tumor, potentially spills the tumor a little bit, that's a very bad thing, of course. So I would caution use of staging laparoscopy.
Okay, and then sometimes therapy is performed since surgery is not an option in retroperitoneal liposarcoma. Is it possible to treat it in its entirety with therapy? Have you seen cases where chemotherapy treated sarcoma and no surgery was required later?
Yeah, it's a great question. The answer is no. There are situations when the surgeon feels that the tumor cannot be removed completely. That situation is called unresectable. That's the medical term for it. And those are situations where a patient would get chemotherapy, systemic therapy, radiation therapy in an attempt to try to see if we could shrink the tumor to make the patient resectable as opposed to unresectable. However, I'd say that unfortunately is not that common. I would say that it is important to get a second opinion with someone who is experienced in sarcoma. And even for things like retroperitoneal sarcoma, experience in that particular type of sarcoma, that particular body location, to render an opinion about resectability.
And I'll just add to that. Yeah, so the only way to really get rid of it would be with surgery, but just sometimes, so we want to make sure that you go to a sarcoma surgeon to see if that's possible. So if not, then we can try to treat it systemically with medication. It won't get rid of it totally, but we can always readjust, you know, as time goes on and it's getting smaller, we can always reassess whether it becomes resectable. If not, oftentimes we just have to leave the tumor in, but if it's not growing or organ threatening, you can still live with it as long as we keep it under control.
Correct. And I do want to add that sometimes at our institution, at other institutions, other sarcoma centers, we do give systemic therapy specifically, not just to try to shrink the tumor, but to try to control any potential microscopic disease that may be elsewhere in the body. So the thought process is that if the tumor is, let's call it borderline resectable, we probably could get it out. It's a very big operation, a lot of morbidity, could be a long 2 to 3 month period of recovery after surgery. Sometimes we give drug therapy, systemic therapy up front so that after this operation, the patient may or may not need additional therapy to get rid of disease that could be elsewhere.
And then just one other quick question. If margins are clear, what are the chances of it coming back?
Yeah, that's a kind of a complicated question. The chances of it coming back are less, so the recurrence rate is better. The incidence of recurrence is lower. However, it really depends on the subtype. It depends on the subtype. It depends on a lot of factors, how wide the margins were. Was it just microscopic? But ultimately, I'd say the most important thing is the subtype.
And this one is kind of, I think this one is good to address because it's kind of like an urban legend. So if you can talk about this.
Sure.
Does sometimes surgery increase the chance of spread of tumor, especially for localized sarcoma, or is it more related to the genetic of the disease?
Yeah, well, the answer to the question, does it spread or not, is no. I would say that is a urban legend, if you want to call it that. But I don't think we have any evidence. In fact, I'm not aware of any evidence that says that surgery can spread tumors. I actually think what is happening in that situation, meaning like a patient has surgery and then shortly thereafter, 1 month, 2 months after surgery, it's spread everywhere. So in that situation, I think what's happened, it isn't so much the genetics part of it, but I think it is presence of microscopic disease already at the time of surgery. It's kind of what I was referring to earlier about the giving systemic therapy before surgery, because there may be cells that are sitting in the lungs that we just can't pick up yet on CT scan. So I think that's what's happening as opposed to spreading tumor cells at the time of surgery.
I think we have a couple more questions, but we're running a little bit over time. So maybe we'll try to answer those questions during the course of the day.
Great, thank you.
So now I have the pleasure in introducing Dr. Stephen Oppenheim, and he is an assistant director of the supportive care medicine, oncology, and associate professor of medicine at Cedars-Sinai Health System at the Samuel Ocean Comprehensive Cancer Center, Department of Internal Medicine. So essentially specializing in palliative care. It's a special fellowship through internal medicine, and it's a very important topic that he's going to discuss today. So a warm welcome to Dr. Oppenheim. I think, and you're on mute, sir.
Muted.
And then,
I'm sharing my slides.
perfect.
Then we will put it into slide share. Can you see the slides?
Not, oops. We can't see them yet, Dr. Oppenheim.
Okay.
I still see your face, so,
Okay. We're working on it.
okay,
All right, if not, I have them as backup.
Yeah,
I do as well.
here they are.
Oh, there we go.
Perfect. There you go.
Now you can see my good. Okay, thank you. How are we now? Okay, so thanks so much for asking me to speak today. I love speaking about palliative care and want to introduce it and make sure everybody understands what it is and what it isn't. And then we'll talk about how it can be applied to the care of people with sarcoma. I interchangeably use palliative care and supportive care. They mean the same thing. And at Cedars and many other cancer centers, palliative care has really been renamed to supportive care. It's more easily accepted by both patients and medical providers. And it really speaks to more of what we're doing, which is supporting people who are going through cancer therapy. So the question I love to ask groups, just think for a moment, what do you think about when you hear palliative care? And since we can't be interactive, I'll let you speak silently to yourselves. But many times people will come up with things like, it means I'm going to die, it means there isn't hope. And that is exactly not what it means. And so the World Health Organization defines palliative care this way, that it's an approach that improves the quality of life for patients and families facing life-threatening illness through prevention and relief of suffering by means of early identification and assessment and treatment of pain and other problems, including physical, psychosocial, and spiritual. Unfortunately, it's a big mouthful, so it's not really an elevator clip, but that's as good as we've been able to define it in the field thus far. I'll say more about that in just a minute, but I want to present a case to you so that I can at least outline some of the ways supportive care can be applied to somebody living with sarcoma. The patient's a 67-year-old woman with pelvic leiomyosarcoma who's referred to supportive care with nausea, crampy abdominal pain, constipation, a 20-pound weight loss, anxiety about her finances, who asks the provider, why is this happening to me? And she's just starting a new sarcoma-directed therapy. So there are a bunch of clues in this case that really point out to all the different areas that supportive care can help her while she's going through traditional sarcoma-directed therapy. I've identified some of the aspects of this case. In terms of the nausea, there's a whole very logical way to approach nausea in the field of palliative medicine. And that's actually why I went into the field when I was humbled as a trained internist at an academic medical center, that I didn't know how to treat nausea very well until a palliative care specialist showed me how. But in this case, the patient had compazine, and I'm going to use all brand names here just because they're more recognizable by patients and consumers. Compazine was added to Zofran, and they were given more effective laxation for their constipation. The pain was treated not only with an opioid, but with Levsin, which is hyoscamine. It's an anti-spasmodic that can directly affect the spasm of the smooth muscle in the intestinal tract that was contributing to her pain. And again, she was given better laxation. Palliative care focuses a lot on bowel function. If pain is the 5th vital sign, bowel movements are the 6th, because we're always asking people about their bowel function and making sure that they're having regular bowel movements. In this case, for her constipation, the Colase was stopped because it's not a very good laxative agent. It's really just a stool softener. And she was given natural Senna, which is a stimulant, and Miralax, which is a brand name for polyethylene glycol, which is an osmotic laxative, and those two together usually always work for constipation. But there are many other agents that can be used if those don't work. Her weight loss was addressed by a dietitian referral, one of the members of the palliative care team. She underwent a depression screen, and cannabis was discussed as one of a number of options that could be used for weight loss. Additionally, her anxiety was addressed by referring her to social work. We have many trained therapists in our team who are social workers, and she also was given referrals to support groups. Her finances were initially addressed by the social work referral, who could refer further for resources and other options, possibly regarding disability entitlements. And lastly, she identified that she has an element of existential distress, and she underwent a spiritual assessment and was offered a chaplain referral. And I'll talk more about all these team members in a moment as we go through that. But just to switch back to what is palliative care, it's a recognized medical subspecialty and has been now for 12 years. To become a specialist, there's a fellowship that's required and passage of a board exam every 10 years. There are about 4,000 board certified physicians in palliative medicine, and now about 94% of hospitals with 300 beds or more have a palliative care team. As I've already mentioned, palliative care really is the same as supportive care, and in cancer and sarcoma care, we like to refer to it as supportive care. So other aspects of supportive care for cancer, when a patient asks me, doctor, what kind of doctor are you and what are you going to do for me? I usually tell them I'm here to provide you support as you're going through cancer treatment, and that we focus on symptoms that could include pain, nausea, anxiety, insomnia, loss of appetite, and we also address psychosocial existential distress. And I'll talk more about what I mean by that. The supportive care specialist will help coordinate care with the treating oncology team, but usually turn to the primary oncologist as the lead of that team, as well as the patient and family being the lead of that team. We help with communication between the team members, the family, and the healthcare system. And lastly, facilitate advanced care planning, discussions and support around prognosis, and help with end-of-life discussions. So that's tagged on at the end. It's not the main focus of supportive care, but it is an important part of the skill set that supportive care experts have in communication about these issues. And most importantly, and I think you've heard about some of this already and we'll hear more about it, that some of the other additional palliative and sometimes curative approaches for sarcoma include chemotherapy, surgery, radiation. And I'm not going to be talking about those because palliative care really works along with the experts in these fields on this slide to provide treatment. So the supportive care team includes supportive care medicine, palliative medicine specialists. Often we have survivorship and rehab medicine, specialists in cancer rehabilitation, psychiatry, pharmacy specialists in palliative medicine, pharmaceuticals, social work, who are able to offer psychotherapy and access to resources, clinical nutrition specialists who are trained in cancer dietary issues, chaplaincy or spiritual counselors, and nursing. So I just want to highlight the ASCO updated guideline, which speaks to the recommendation by the American Society of Clinical Oncology that all patients with advanced cancer ought to be offered concurrent palliative care. This is a consensus statement that's been out now for several years. Sometimes the challenge are the resources that all cancer centers have enough palliative care experts to provide this. And this, again, is really just to provide support while people are going through cancer-directed treatment. We tend to have more time sometimes than some of the other specialists have. Usually our initial visits are an hour to an hour and a half, and we leave a half an hour to 45 minutes for follow-up visits where we'll spend time just processing the issues that patients and families have around going through cancer treatment. So some of the documented benefits of palliative care that have been shown through the literature include improvement in quality of life, increased survival in some patients with cancer who are also getting palliative care, increased patient and family satisfaction, improved patient and family coping, with documented decrease in depression and stress in patients and caregivers, along with a decrease in the burden of decision-making for patients and families. So these are really the benefits of getting a palliative care, supportive care consult when cancer or sarcoma are being dealt with. Some of the common physical symptoms in sarcoma include fatigue that can be from sometimes the treatment, the tumor itself, and complications of the tumor. Loss of appetite, pain, shortness of breath or cough if the sarcoma goes to the lung, and nausea and vomiting. I don't have time allotted today to go into the granular aspects about how we palliate many of those symptoms, which sometimes include direct treatment of the tumor itself with cancer-directed therapy, but there are also other palliative medicine approaches for that. Some of the emotional challenges that come up in sarcoma, understandably, include anxiety, sometimes depression, or a lesser aspect could just be an adjustment disorder with depressed mood or anxious mood, which most people understandably experience when given a diagnosis of sarcoma. Family distress, caregiver distress, and even pre-bereavement issues when senses of loss emerge if people are approaching getting sicker or possibly dying. There are also practical challenges that come up in cancer and sarcoma, including issues with finances when people may not be able to work as they once did, issues around insurance, not only for healthcare, but life insurance, long-term care insurance. Our social workers can help direct people into how to access these entitlements. Housing issues come up many times. Sometimes people transfer or move towards cancer centers, which are far from where they live, and they may need temporary housing assistance. That many times there's help with that through various entitlement programs. Help with transportation, sometimes food insecurity, reduced mobility and home care needs, and caregiver availability. And these are some of the things our social workers and sometimes rehab specialists can help a lot with. The existential or spiritual needs come up, I observe in practically every human, every patient, and many times when I ask people what their religious or spiritual beliefs are, many people will say, well, I'm not religious, but we all have existential issues in life that may come up through having a sense of meaning or purpose in life. What was my life all about? I want to leave a legacy, or there may be specific religious needs in terms of desires for specific religious program, losing the sense of the word, but to have the sacrament of the sick for Catholics, or certain prayers for other religious programs. Some people need reconciliation with family, a sense of forgiveness, wanting to leave a legacy. And chaplains are the experts at doing this, and they know how to speak to people whether they have a religious program that they're involved with or not. And chaplains are not there again, just to talk about end of life, but they're just to talk about human existential needs. Some of the things that can identify existential issues that patients might say are, why is this happening to me? Did I do something wrong that this is happening? This is usually a clue that I might explore existential issues with people and hopefully have them accept consultation with a spiritual care counselor. Or they might mention they have a sister they haven't spoken to in 25 years, or wishing they could see their grade school children have families. And if there is a terminal illness, that may not be possible, but there are wonderful ways to leave legacies to family members when we're no longer going to be there. And chaplains help with that. So that was my last slide. And I think I went fairly quickly, and it looks like there may be time for questions, if there are any questions.
Well, thank you so much. That was really great. We do have some questions. Says, does exercise, yoga, acupuncture, alternative therapies, including naturopathic support offered as part of palliative care?
Some palliative care programs have those programs involved with them. And if not, they generally refer to those programs. Exercise is the best treatment for fatigue related to cancer. I always give that a plug.
And I think that that's all the questions now. I'm sure there may be some more coming in. Maybe, let me see. Okay, oh yes. Is palliative care covered by insurance? I have not been offered.
Palliative care is generally offered by insurance, yes. Most cancer centers have palliative care programs. The physicians, the rehab specialists, the psychiatrists generally bill just as the oncologist, the surgeon, the radiation therapist bill the insurance. And then generally the other aspects, social work, spiritual care, dietitian, those are included with the program and generally don't cost more.
And then the question here, how long can a patient be under palliative care? Can they be on and off, or they stay on, or how does it work?
So people can receive palliative care from the moment of sarcoma diagnosis until they're cured. And then we follow them for survivorship, or if they're not curable, through all their treatment and through the end of life. There's no time limit, and people can go on and off supportive care or palliative care as they desire.
Great. Thank you again. Let me just see if I think we're running out of time. So, okay, let's see. Are there oncocentric versions of psychiatrists, therapists, etc.? Does it make a difference?
Yes and yes, that's the short answer. The psychiatrists I work with are specialized in cancer psychiatry, yes. And the therapists as well, both in the center where we work and many therapists we refer to specialize in cancer psychotherapy.
And then how can nurses help introduce the notion of palliative care to their patients as they spend a lot of time with them during their treatments?
One of the best ways is to first inquire and do a nursing assessment in terms of the physical, emotional, practical, spiritual, existential issues that the patient might have. While in our center, the treating oncology team needs to make a referral to the palliative medicine specialist. In many centers, including ours, nursing referrals are often the trigger that result in a dietary, social work, and spiritual care referral. So the nurses can make the referral directly. But it depends somewhat on the politics of each center in terms of how that's done.
Perfect. Thank you so much, Dr. Oppenheim. And we're going to take a quick 3-minute break, and then we will be back, and I'll introduce Dr. Hakimian.
Thank you.
While we're taking the break, I'll just answer some of these questions. Maybe a silly question. I've already had my surgery and was wondering, can I get a second opinion to be obtained while there's no tumor present, just to see if it was properly diagnosed by looking at the scans, etc. You can always, get a second opinion. Now, granted, if it's been over a year since the surgery, I think that probably wouldn't necessarily be worth it. But if it's been, relatively soon after the surgery, it's always good to go to a sarcoma center, and then you can have the pathology reviewed, make sure it's a pathology that they agree with the pathology, to see is there any additional treatment that may need to be done to decrease the chance of it spreading. Also to review the slides, make sure that the margins were negative, and to look at the imaging after to see if there was any tumor left behind. So it's not unreasonable to do that. Now, if it's a few years back, it was a few years ago, and your scans have been clear, that may not necessarily be worth your time and expense. And then I think under survivorship, how long is care provided? Till you're 100 years old. So once, we always like to have our patients be followed for the rest of their lives. It doesn't necessarily mean you need to get scans for the rest of your lives, but at least get the physical exam, at least be seen with blood work once a year. I like to keep my patients till if they move or whatnot, or if I move, but otherwise we want to keep them with us. And then they also give hope to other sarcoma patients to say, look, I have my patient I'm still following. It's been 20 years, 30 years. So once a year visits are fine. Okay.
Perfect.
All right.
Thank you so much, Dr. D'Amato. It's now my pleasure to turn it over to Dr. Hakimian. Behrooz Hakimian, MD, is with Cedars-Sinai Health System. He is assistant professor, radiation oncology. And Dr. Hakimian, over to you. Thank you for being with us today. Dr. Hakimian, I believe you're still on mute. Let me unmute you. Oh, you got it. Okay, we're on. You're not muted, doctor, but I can't hear your speaking. I see your screen, but I'm not sure if your mic is working. We can see your slides, but I don't believe your mic is working.
he may need to call using his phone on the number.
Dr. Hakimian, let me forward you the call-in number so you can actually call in using your phone. Please stand by
Yeah.
1 second.
So we have a question about where are the answers to yesterday's questions. We can try to find those. Let's see what other questions we have. Thanks for the time. Just going to take this time to also say we're going to be giving away the iPad, and we want you to fill out the evaluation forms. So we have a brand new iPad, okay, and the iPad pencil. And anybody, this is for patients and caregivers that, and then we also have for anybody in the medical field, we have a brand new book that was just published, Sarcoma, Evidence-Based Diagnosis and Management. And you recognize some of these doctors. We have Dr. Trent, Dr. Rosenberg, Dr. Pollack, and Dr. Delaney, who are surgical oncologists and radiation oncologists. So this is for anybody that's in the, you can choose, you know, I don't know if a patient wants this because there are a lot of technical terms, probably want their iPad, but so fill out your evaluation forms. That's my shameless plug. Okay.
That was great. Yeah, very, very good. And there is a question about where are the answers to yesterday's questions? So we are posting the live stream from yesterday on Facebook, and we are also editing the video to post on YouTube later this week, and that'll have some of the questions populated within that, so you can just reference it within the video section. And then we did have some write-in questions, and we'll publish that on our website too, so you can reference that. I'm seeing people want the book.
I know, so yes, that's okay. So you can just, I mean, you know, if you win, if you get picked, you can, you know, choose whether you want the iPad with the pencil or if you want the book. That's fine either way. You get a choice here. And then, you know, as we said, these conferences, one of the main things is that we are trying to, if you haven't heard the underlying subliminal or not subliminal message, that, you know, we do want people to get second opinions and be treated by, or at least oversought by sarcoma experts, and Sarcoma Alliance does provide funds for patients to get second opinions. So any donations would be welcome when you fill out your evaluation forms, so we can help get patients to be treated properly.
Can you hear me now?
We can hear you.
Yes.
Excellent.
Wonderful.
Thank you.
Sorry, I had some technical issues here. I want to thank all the organizers for inviting me over here. It's really great honor to be here. I'm a cancer survivor myself for the last 4 years of osteosarcoma. So It's really a pleasure. Can you guys see my screen? Okay.
We can.
Okay, so how should we feel about radiation? This is an open-ended question. I don't think anybody would be laughing at this, but there's a lot of anxiety, there's a lot of anger, there's a lot of questions about this, and hopefully I'm going to ease this thing for you. What exactly is radiation? Radiation is a form of energy. Basically, you have a spectrum of radiation anywhere from the radio waves to high energy gamma rays. And as you can see, electricity is actually on the lower end of this, and this is actually very, very low frequency, so it has a very low energy. It's not something that will cause any harm. Whereas if you start increasing this to the radio, light is over here, to X-rays and gamma rays, this tends to have a higher frequency of radiation. They can potentially penetrate a lot more and can cause more damage to the organs at risk as well as the tumor. So why do we use radiation? Basically, what the radiation does is, as it goes through the body, it damages the DNA of growing cells. A few things can happen. First, this damage can be severe. The cells are doomed to die. Basically, you break the DNA in two different parts. So when the cancer cells are going to divide, they're going to misalign. They're going to find out that they lost some ability to do their function, and eventually will die, and the body will come and eat those up. A lot of times, this damage is very minimal and can be repaired. No harm is done, and cells continue to divide. So when the radiation gets into the body, passes through the normal tissue until it gets to the cancer, and then it exits through the other parts of the normal body. So what can be differentiated between the tumor and normal cells? Fortunately for us, the cancer cells are not able to repair themselves well compared to the normal cells and preferentially die. Now, we have been doing this for many years, and we know that for the last 100 years that we have been using radiation, if you give the radiation smaller doses, you can actually use that to improve on control of the disease and minimize any risk of radiation treatment. And fortunately, in the last 20 years, we have seen quite a bit of improvement with our delivery of radiation treatment, with our techniques that we have, and we are not seeing as much of a complication as we used to see many years ago. One thing I want to mention is radiation is a localized treatment. It's similar to surgery. So if you're going to give the radiation to some area, it's not going to affect the other parts. So if I'm treating somebody's leg, it will not cause hair loss or other component of nausea that we usually see. So what happens when somebody comes and tells me that the patient is referred to me? What are the goals? That's the first thing. Are we going to be able to cure somebody from radiation? Are we going to be palliating somebody from radiation? Goals, I think, have been discussed before. That's something that we need to really understand. If it's curative intent, we want to make sure that the disease is only in the primary site of the disease. And the paradigm is shifting a little. Sometimes these days, we also tend to treat some of the areas that may already spread, given that there are only a couple of areas. So it's not something that we can cure patients if they have widespread disease. But even with one or two spread of the tumor, for instance, the lungs, surgery can be done, and it makes sense to consider this as a potentially curative intent. Now, there are tumors that actually grow very slowly, and there are tumors that grow very fast. And traditionally, when we do the radiation treatment, there are diseases like lymphoma, which basically melt down with the radiation. On the other hand, there are tumors like sarcoma, which are not going to be melting down. They're just going to stay there. And as a matter of fact, sometimes there may be some swelling, sometimes there may be some necrosis. And given all those considerations, the surgery or the radiation may have different intent. Given the fact that we give the radiation in multiple treatments, it can take several weeks for us to see the effects of radiation. Now, if I deal with a 5-centimeter tumor, sarcoma, for instance, it may require probably about 100 gray of radiation, 90 gray of radiation to eradicate the tumor in that area. And those are not the doses I can give easily. So the purpose is to actually combine it with the surgery. And I think Dr. Tseng has done a great job of discussing the surgery as in combination with radiation, that the two of them can actually be quite effective in terms of controlling local disease. Now, sometimes tumors can be widespread, and we are asked to evaluate the patient. It might be just that their tumor is causing pressure on the spinal cord, and radiation therapy can be used for that. Or it may be just a tumor that is spreading inside the lungs and is pressing on airways. Certainly radiation can be helpful, relieving some of the pain. Those are the palliative treatments that we are talking about. Again, surgery is great to eradicate the trunk of the tree. However, there are roots that cannot be seen, and those will eventually grow back. So the purpose of radiation is to eradicate those roots for us. As I mentioned, we require a lot of radiation if we want to take care of the tree itself. So it's usually a combination of the two. Now, as Dr. Tseng mentioned, we can do the radiation preoperatively, which means that we can do it before surgery or we can do it after surgery. For different reasons, usually when we do the radiation before surgery, we require to give a much less dose of radiation therapy, anywhere about 45, 50 gray of radiation therapy. And the tissue hasn't been compromised yet. But the problem is once the surgeons actually take the patient to surgery and operate on this area, the tissue is not going to heal well. So we have some issues with the healing process. On the other hand, when I see a patient who had the surgery before, I have to include the entire scar. I have to include the entire body area. And also, in order to overcome some of the effect of the surgery, which means that the tumors have become hypoxic, they're not getting enough oxygen, I actually have to give a higher dose of radiation therapy. And that's where the complication of fibrosis and scarring happens. Now, when you compare the scarring versus wound issues, I think most of us consider scarring to be more serious condition and will take the risk of doing the little bit of a wound infection and dealing with that beforehand, and could potentially be quite a lot of help for that. The paradigm in radiation is the fact that we also are treating sometimes tumors that have spread already with a very, very high dose of radiation to the point that we can actually eradicate those locally, what we consider stereotactic body radiotherapy. For instance, somebody may have a tumor in the lungs. Usually chemotherapy should be taking care of that. Usually surgery can be taking care of that. But some patients may not be candidate for that, or sometimes the tumors have grown on chemotherapy. Stereotactic radiotherapy can be quite effective for that, which is basically a very high dose of radiation in a very confined space. So what happens when somebody comes and see me? First, we need to do a consultation. We go over all the tissue diagnosis, all the pathology, and we discuss the goals of the treatment. And a lot of times we also talk with the surgeons. And sometimes things may not be so apparent. There may be some concern about the surgeon that tumors might have bled. There might be some contamination. We also need to have that in consideration. Now, as you know, sarcomas are not just one type of disease. There are some that can potentially go to the nodes. So we want to make sure we evaluate all the diagnostic studies, PET scans, MRIs, CT scans, to make sure that there is no spread of the disease. And if there is, if it's something that is very close to the primary site, that we can potentially include that in the field of radiation. Once we do that, because we want to make sure that we give the radiation over almost 5 weeks, we want to make sure we can set them up in the same position. And we want to make sure that it's a very reliable setup and the patient is very comfortable. So there's a process that we call simulation. That's basically when the patient comes in. These days, we do the simulation with a CAT scan that we do. And potentially, we figure out the exact volume that needs to be treated with this CAT scan. We three-dimensionally can construct the volume of the tumor as well as the volume of, for instance, the femur that is next to it, the bone, the long bone in the extremity, or the potentially where the drainage of some of the areas are, or the nerves that might be that we have to consider. Now, we do the treatment on Monday to Friday basis. Tumors do grow on the weekends, but I think most of it's an outpatient basis. So, and traditionally it has been done Monday to Friday. It works very well. If we do the treatment in one fraction, usually stereotactic radiosurgery, we do not use that for the standard soft tissue sarcomas unless it's metastatic. However, shorter course of treatments are becoming more popular these days. And then we follow the patient for both short-term as well as long-term to make sure that we have not caused any harm or if there's anything that can be done about it. As I mentioned, the process of simulation is usually done with making a device that can set up the patient so we can put them in the same position. It could be just this blue pad that you see that will make the patients more comfortable so they are not moving around, and also, or it could be just a mask that we do. Now, we obtain a series of images with a CAT scan so we can actually know exactly what the three structural dimensions of the tumor looks like. What happens after we do the simulation, we ask the patient to come about a week later. In the meanwhile, we go over the CAT scan. If there's an MRI, PET scan that we have to use, we can actually register that with CT scan so we have a better images. We know exactly the location of all the structures that we really want to do, and we'll proceed. The planning is done off-site. The CAT scan that we do, for instance, this is a patient of mine that had a tumor in the femur again, and you see the color washout. The whole idea is you really want to blast the tumor and minimize the risk of radiation to the surrounding area. Now, you see the blue stuff, blue color here. This is a low-dose radiation. The red hot is where the tumor is, and that's where we really want to deliver the radiation. So by coming from different angles of radiation, by giving radiation from different sites, by changing the intensity of radiation, we can basically deliver a very high dose of radiation where the tumor is. And as you can see, just a couple of centimeters away, there's going to be substantial less dose of radiation. And the colors actually indicate that. So also one of the things that we do, if once we start the radiation, we cannot take it back. So there's a lot of quality assurance that goes into our planning. After all, if we're going to be delivering the radiation, we want to make sure we are treating the right spot. We want to make sure all the calculations are correct. So there's a second, third checks that are going to be done beforehand. And each day that the patient comes in, we usually kind of make sure that, not usually, we always check to make sure that the outcome of the machine is going to be the same and the calculations are done correctly. This is the actual radiation machine, what we call linear accelerator, and you can see it's actually in different position. The patient lies down on a table and the radiation is delivered from different angles. So you can see there's 1, 2, 3 different angles of radiation. When we talk about radiation units, we talk about gray. It's like temperatures, Celsius or gray or Fahrenheit. The unit of radiation is gray. And usually each day that the patient comes in, they usually get about 1.8 or 2 gray. And then again, we want to give about 45 to 50 gray. So that's going to be about 5 weeks of radiation treatment. Sometimes instead of giving the radiation from outside, we do it inside through needles. It's called brachytherapy, and I'm going to give you a couple of slides on that. So what changed in the last 20, 30 years since my residency? In the old days, with the radiation that we did was low efficacy. It was not as efficient, but it has also had toxicity. Now, we can do a lot better job. We can actually reduce the toxicity, and also we can do a much better job of improving on efficacy of radiation. So those are some of the things that can actually improve on how we can do a much better job of controlling the tumor. Basically, there are different modes of radiation therapy. Two-dimensional radiation therapy is what we used to do. Basically, you use X-rays and you deliver the radiation. You do some blocks. 3D conformal radiation therapy is when we use the CAT scans and then we tell the computer these are the angles of radiation I want to come up with, and they can deliver a very good dose of radiation. And to improve on that, sometimes we actually use intensity modulated radiation therapy. What IMRT is basically as the radiation is being delivered, there are some blocks that are going to come inside in front of the beam of radiation. It can potentially block some of the structures that we really want to avoid, like if I'm treating the chest, it might be that I'm blocking the heart from that angle. So the dose to the heart is going to be minimized. And we can deliver much higher dose of radiation to the tumor, as well as giving the least amount of radiation to the structures that we really want to avoid. Some of the examples, for instance, when it comes to sarcoma, if you are treating retroperitoneal sarcomas, this is something that can potentially reduce the dose of radiation to the kidneys. Stereotactic radiotherapy, basically, that's when we do very high dose of radiation. These are 1 to 5 treatments, very localized. Again, it's something that our field is actually exploring to see if we can actually use that to deliver the radiation even for intact tumors before surgery. It's experimental at this point. Intraoperative radiation therapy, or IORT, is basically when we deliver the radiation inside the operating room. There are devices that we can take to the operating room, and the radiation is delivered very locally where the surgical cavity is. Finally, brachytherapy is a kind of radiation treatment that is given inside the body. Basically, we put the catheters inside the tumor bed. It requires a specialized radiation oncologist. Fortunately, one of my colleagues actually does this brachytherapy all the time, and does a great job of putting the radioactive material very, very close to the surgical cavity. For somebody who has primary sarcoma and has not received any radiation therapy, I don't think brachytherapy by itself is the only choice. I think usually we use that for when we are dealing with recurrent tumors, when we are dealing with areas that are requiring a high dose of radiation therapy and we cannot deliver that from outside, then we actually consider brachytherapy in this way. And last but not least, there's such a thing as particle beam therapy. I'm sure a lot of you have heard of proton beam. Proton beam is basically a form of radiation therapy that uses particles. Particles are a lot more heavier than standard radiation therapy that is basically X-rays. In order to accelerate these particles, it requires a fairly large linear accelerator or cyclotron to produce it, and it's also very expensive to produce. The advantage of proton beam is it can actually deliver the radiation in a very finite area. So imagine if you have a sharpshooter and you're trying to shoot something from a mile away, the proton beam can actually be that particle. However, sometimes this is just going to be adding extra to the cost of delivery of radiation treatment, and there are only a few centers in the country who have proton beam. To reiterate, this is a two-dimensional radiation therapy. Basically, X-rays are done to deliver the radiation. 3D conformal radiation therapy is when we use CT scans, and again, this is a color washout again of somebody's chest wall or breast that we're trying to deliver the radiation treatment. We know before the patient gets on a table what dose is going to get to the actual areas. We can actually modulate the radiation. So imagine this circle that you see 30% is the spinal cord, and you have a tumor that actually wraps close to that area. We can differentiate the dose of radiation therapy. So 95% of the dose of radiation can be delivered to the tumor, and only 30% is delivered to the spinal cord. So it can actually spare the function of the spinal cord so we don't cause any injury. And this is what we use by IMRT. Now, I also mentioned stereotactic radiotherapy or SBRT. Basically, these are very high dose of radiation therapy and delivered to very finite area. The idea here is you want to spread the radiation. You just don't want to give the radiation from 2 or 3 different fields, but you may want to give it with maybe 100, 200, 300, 500 fields of radiation, all converging on where the tumor is. And each one of these can avoid the critical structures that are contributing to. So at the end, you're going to end up with an area that is kind of red with a high dose, and then the area that is cooler, like a green dose, and then small dose of radiation to the normal structures. As I mentioned, you can actually kind of deliver high dose of radiation. This is an X-ray. You basically, in this case, you have done exposure at some areas that are quite dark, and then there's areas that are not getting any exposure, and you can see that somebody actually was smart enough to print Einstein's picture over here, and this is an X-ray of that. Again, stereotactic radiotherapy, high doses. We are delivering the radiation from multiple fields, whether it's static or these days we use a lot of arcs, which basically the radiation goes around the body around 360 degrees and deliver the radiation in that area. And then we can use 2 or 3 different arcs. So the beam of radiation, the intensity is changing as the delivery of radiation is done simultaneously. Now, what I have done here is it's great that we can do all this work on a X-ray behind the computer, but how can we know that we can actually deliver the radiation the exact same way? On the day that our patients come in, we actually do a CAT scan. The purpose of the CAT scan is to make sure that everything lines up to the images that we initially obtained. As you can see, there are 2 sets of CT scans here. One is the one that is better quality. This is the one that was done at the time of the CAT, of the CT and simulation. Second one is the time of the setup. And we can superimpose this together on top of each other to make sure that everything lines up perfectly, and then we can do the treatment afterwards. So it's a great way of delivering the radiation treatment and also make sure that everything lines up perfectly before the patient starts their treatment. This is another set of quality assurance that is made to make sure that we are right on target when we do the treatment. I did mention intraoperative radiation therapy. This is a device that delivers the radiation inside. This is for breast cancer, not sarcoma, but the idea is that if you have dedicated machines, you can potentially deliver the radiation. The treatment is basically only a few millimeters. It's not something that we consider very good for sarcoma unless the margins are very close to the nerves that we're trying to not sacrifice the nerve. This might be another alternative to delivering the radiation. I did mention proton beam. What you see on the right side of the screen is the radiation doses. Again, blue is cold, red is hot. And if you're treating, this is somebody, it's a young boy with medulloblastoma. A lot of times we treat the entire spine with that. And as you can see, the abdominal area gets the full dose of radiation therapy. Whereas with the proton beam, your fall off is going to be much better. So there's really not much exit dose beyond the entrance. So it actually works much better for a young kid who is growing, and we really want to minimize any risk of complications. And I did mention brachytherapy. Basically, we put catheters in, And as you can see, the doses that we see here, the nice thing about brachytherapy is actually the radiation stuff coming from outside inside to get to the tumor. It's actually delivered from inside out. So radiation is delivered where the tumor is and give a very high dose of radiation, and the fall off is going to be much faster. So it's a great way of doing the treatment. It's usually, again, something that we do not on a regular basis, but maybe for recurrences. Now, one thing I want to say is that radiation will not cause any mutations that some people will deliver, will have 3 hands. I'm going to end at this point. I'm ready to answer any questions.
Okay, we do have some questions. We're running a little bit late. The problem is I put that I would like you to answer them live, and I don't know if you'll be able to not answer them live. So I'm going to just go a little bit quick. So does palliative radiation only indicated for symptom reduction and does not stop disease progression or control the metastatic site?
So palliative radiation therapy is when somebody has symptoms. It will actually reduce the size of the tumor. It will, in the site that we radiate, it will improve, the main thing is it will improve the quality of life. So somebody who has bony metastasis, they're miserable. Radiation therapy can actually potentially reduce or completely make their pain go away. At the same time, we can actually deliver high dose of radiation to that site to eradicate the tumor on that site, but that's only localized disease. So if they have other diseases, it's not going to help them out.
Okay, and then let's see. Okay. Is giving radiation after laparoscopic total hysterectomy with morcellation and chemo common to a LMS stage 1B?
Highly controversial. If you talk to a lot of GYN oncologists, they think that the radiation therapy will not be helpful. I think we, as radiation oncologists, think that local control of the disease in the pelvic is important. Usually with these things, they could potentially spread to the other parts of the body. Radiation will reduce the chance of the cancer coming back in the pelvic area. Saying that, what are the potential problems when the tumor comes back in the local area? It can cause a lot of pain. It can cause a lot of obstruction. So if we can prevent that from happening, I think we have done patients a great favor. Again, it's a little controversial. There's going to be some side effects from that. So that's where the GYN oncologists do not like the idea of using radiation for leiomyosarcoma sarcoma of the uterus.
Okay, and then what do you think about treating localized alveolar rhabdomyosarcoma on extremities? Radiotherapy versus proton therapy? Maybe also if you could just explain, when we use proton versus electron versus standard.
So, sure, great question. I think the dose of radiation that we can deliver with whether it's proton beam or versus it is photon is the same. So the advantage of proton beam is it can potentially spare some of the normal structures. If somebody had prior radiation treatment and we have to re-radiate the second time around, certainly proton beam can potentially reduce the toxicity from the radiation. If somebody is young, let's say 12 years old, 15 years old, 20 years old, the radiation that with photons, it doesn't stop, whereas with the proton, it does. So most of the time, we like to actually use photons, but there are some cases, selected cases that we use proton beam. Now, it also has to be balanced by where these proton beam centers are. There are not that many of them around, and if you have to travel, live in another state for 5 weeks or so, you may not be feasible at all.
Okay, great. And then there are some other live ones, but actually a lot of them for our next speaker, a radiation oncologist, and one is a question comparing the two. So maybe after Dr. Venkat, interventional radiologist, And just because some of these questions are to the radiologist and the radiation oncologist, and I know it gets confusing, and I just even stumbled on it. So radiation oncologist gives radiation, special residency, 5 years, no overnight call, which we won't talk about that. But anyways, and then the, a radiologist is a different residency. And then there's an interventional radiologist, which is a fellowship of that. So different things, but they kind of, patients and even me, kind of stumble on the words. So, so some of these questions are for Dr. Venkat, and some it will be nice to have the two of you, discuss the differences. So, so we'll, and then I think some that Dr. Hakimian, you can, type in maybe some of the other questions.
Sure.
Okay, thanks so much. So sorry, we're running over. We're trying to be tight on time, we'll see. I'm used to always running behind, so it's difficult for me. But our next speaker, I'm thrilled to have, and thank you so much. That was really great, very educational.
My pleasure.
And our next speaker is Dr. Venkat. She's an assistant professor of interventional radiology at University of Miami, Miller School of Medicine. She was born in Brooklyn, New York, and grew up in Detroit. And after obtaining a BSc in chemical engineering and a BA in English language and literature at the University of Michigan, she completed medical school at Wayne State University School of Medicine in Detroit. After residency, she completed interventional radiology fellowship at University of Miami School of Medicine, where we saw how great she was, and we kept her on as faculty. And she's on my speed dial, and we always using her, very, very helpful. Patients really like her, so excited to have her here today.
Morning, good afternoon. Thank you so much for having me. It's absolutely a privilege. It's a huge privilege to work with Dr. D'Amato and be part of the sarcoma team. I can't tell you how much I learn like every time we hang out together, and it's the best tumor board to ever be to. Some of the questions I think I can sort of answer as we go along. Just send something along. If I start talking too fast, stop me. And I'm allowed to make fun of radiation oncologists. It's what my sister does. But if you look at how our specialties were born, we're kind of both children of the same fathers. Let me try and share my screen. Sorry, I put the questions in the middle of the talk. Questions in the middle of the talk. So, I was asked to come and talk a little bit about a radiologist's role. Half of the talk I'm kind of underqualified now to do, even though we train in diagnostic radiology. I am super, super spoiled, and I do procedures all day, every day, all day long. It's a dream. So what I'm going to try and talk about more is just becoming an informed patient and being your own advocate when it comes to imaging, treatments, and being able to at least speak the language of what imaging you're being signed up for and why. And then a little bit at the end of what we do. We're a very young specialty, and we have a lot to do to prove ourselves. But that's kind of a different talk as we go along. So I'll start in the diagnostic world. As every radiologist, our job is to keep the radiation low. So as low as reasonably achievable. We believe in imaging gently. I take care of a pediatric population a little bit, not as much as I used to. So we make some pretty conscientious decisions of what we image, when, and why in all of our different patient groups. The two modalities that we love that have no radiation are ultrasound. Ultrasound's fun. It gives you a decent amount of information. It's a very handy tool, but not a lot of detail. And it's getting a lot better too. If you go to different places, we have ultrasound guided contrast just to get more information out of a non-radiation modality. MRI has no radiation as well, has a ton of detail, soft tissue, muscle, bone, edema, fluid counts, so much you can learn. But as anyone who has had an MRI, and me personally who've protocoled them, it is loud, it is long, and it's not comfortable. X-ray, quick and dirty, gives you a lot of information about things in alignment. We do less and less of X-rays. honestly. In the MSK setting, it's great to see what the bone is doing and get very, very good information about fractures, alignment, things like that. CT scan is the workhorse of radiology these days. The amount of information you get out of a CAT scan is many times overwhelming. And then, because if you think about it, the images you've taken are a bunch of numbers with the backscatter algorithms and things you can do like that. You can really reprocess information and make wonderful plans and get a lot of information. There is more radiation with the CAT scan. Then, because we're greedy, we try to do one better. So we want to go into the functional imaging world where, hey, if I do a scan, why can't I tell you what the diagnosis is? So that's where a PET CT comes in, and we'll go over that. And that's 2 scans in one, as any patient could tell you. And then there's what I do a lot of, which is angiography. So in this world, your provider could be an interventional cardiologist, pulmonologist, nephrologist, any of us. We're in the room with you getting the radiation. So we're working extra hard to decrease the doses, but you can do some very, very fine techniques and get tumor treatment, diagnosis, therapy with this technique. So just to give a background basic idea of how much radiation do you get from an X-ray. So they calculate from a flight from New York to Los Angeles is about 2 millirems, and a chest X-ray is 10 millirems. So 5 flights kind of thing. Ultrasound. I don't know if anyone's seen ultrasounds, but this is very common ultrasound image of a liver. They're kind of grainy. You got to a little bit know what you're looking for, but you can see a lot again, but it's very, very, very technologist dependent and operator dependent, as well as the tissue quality itself. So you can imagine if you have a very, 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 very large patient where the liver is 10 centimeters away, you're not going to get the ultrasound wave to penetrate and give you the information. It's a great machine. They're portable. These are my technologists. You can take it anywhere you want to go. There are different probes that give you different settings. The worst part is the cold gel. And then just to show you that this is actually a sarcoma on one of the 18-year-old patients that we took care of the other day. And it's kind of hard to tell the mass from the muscle and things like that. We cheat, we know, because I have a picture of her CT scan and MRI, so I know what I'm looking for. But I'll show you how it kind of helps me guide different things that I do. MRI, one important thing to remember, and you'll see it posted everywhere, is the magnet is always on. You don't want to learn this the hard way. But as you can see, it's kind of already a more claustrophobic environment. So big machine, your technologist is outside, you're inside, they're talking over the button. There's a lot of noise from the coil. This is kind of what you see when you can see out. If you can tell, I get claustrophobic in an MR scanner. And these are the crazy images we all share for ourselves, where the floor cleaner forgot that the magnet is on and ends up in there. That can be very scary. So all of our MRI guided equipment, and people do MRI guided procedures, we have to make sure there's no metal in there. You have specialized crash carts. You have specialized zones as you enter from 1 to 2 to 3 to 4 kind of thing, just to avoid this kind of horrific sort of things. But if you put the time in, you get a lot of information. So this is an MRI of a knee, where this is a 22-year-old young man who has an osteosarcoma. The first 2 images you see there are the MRI pre-treatment, and the middle one is the MRI post-treatment. And that kind of corona of high signal around the mass, it shows you all the edema of the acute phase. And as the treatment went in, that goes down, the mass decreases in size, and we see response. And that gives everybody a green light to go to the next stage, which is this X-ray shows you that the joint's been taken out, it's been replaced, and this is the hardware. This is a similar case where we gave chemotherapy through an artery, and this is one of the complications you see. So on the pre-side, you see perfect picture of like lower thigh just above the knee. And the muscles are the light gray. Let's see if I label things. And I kind of label different things on there. And then in the post phase, you can see the 2 muscles that are kind of a little to the left of the screen and in the circle. They get white and angry and inflamed. And the patient will tell you this hurts. So this is actually the muscle responding to the chemotherapy and getting what's called myonecrosis. So again, the MRI just gives you a lot of detail. There's another patient just talking about X-rays. Again, we're giving radiation at this point, but you learn things from it. You can see the bone from the hip all the way down the knee. The poor gentleman had been losing weight for some time, had some back pain, and then literally described that his femur snapped. And it did snap. So as the orthopedic service went through and tried to fix things, you can see they give fixators, they realign the bone. And the last picture there has a small catheter coming down. That's where we put our catheter in the artery to give chemotherapy. Again, post-operative images after everything's replaced. This is what X-ray is great for, showing you a lot of bone and the alignment and things like that. When you need more, and this is the same patient, a CAT scan, well, you can see the abnormality in the bone. The CAT scan that's here shows you what the poor muscle is undergoing. Edema, there's a mass inside there. It gives you information. So the radiation is worth it, so you can actually stage and get a feel of what the disease is. The X-ray doesn't give it to you. This is a PET CT scanner, so another giant donut machine with a really, really, really hard table. It's 2 studies in one. So one is the positron emission tomography, so tomography pictures, positron emission. So that's that sugar that they give you in your IV that lights up when they look in the scan. And then computed tomography is like the CAT scan you just had before, but somebody kind of thought things through, like, okay, so this is one of my patients who's a 49-year-old who's having right-sided abdominal pain and was found to have a liver lesion. Now that's like the most non-specific liver lesion you're ever gonna see. All you can say it's on the right, it's next to the gallbladder. And then he went on to have a PET CT. On the PET CT, this is looking at you from head to toe. Your brain's gonna be bright because it's working hard, it takes up a lot of glucose. Your kidneys are bright because it's taking the glucose out, and your bladder's bright. And then you'll see muscle and different things go up. But there's a small liver lesion here, but that blurrogram corresponding to the detail of the CT scan, why not do one better and put them together? So this is the fused image you're looking for. So this is the gallbladder, these are the nice kidneys, and this is the lesion. This is actually an epithelioid hemangioendothelioma, I can't believe I said it right for once, that we treated. And we did what's called nanoknife or IRE, not gamma knife, which is super confusing for everybody, but you put small probes and you treat electricity in between the probe pairs, and that's done to treat tumor. And what we look for in the functional imaging is, did I get a response? And you really do. So it's light bulb on, light bulb off. So more into what I do, instead of the imaging side, I do image guided procedures. So the one time you'll meet your interventional radiologist all the time, but you may not know because we're kind of shy and a little weird, but is tissue sampling. And our job really is to do a lot of work to help the pathologist make a proper diagnosis. And in this day and age, this is really changing and evolving for a lot of different reasons. So unfortunately, instead of like looking like normal people, we look like this nowadays. So feel free at any time to stop us, ask us who we are, talk to your family on phones, really, really be good at your phone. Don't forget your phone home. And don't do the thing where you say you don't want us to talk to your family, but your family wants to talk to us and then we get trapped in the circle. It's not worth it. We have to get better, and we're working on like upgrading our pre-procedure area with computers that we can video chat with people, because right now, at least in our institution, family isn't allowed in when you come in for a biopsy. So it feels brutal that you're doing a procedure on someone and you don't really get to introduce yourself. And then when you do meet them, you meet them like this. It's bizarre. In our pre-procedure workup, we do consent. If you have questions about a biopsy, any procedure ahead of time, nowadays in telemedicine, you can find one of us anywhere. So set up a clinic visit to find out what we do and why we do it. It's totally okay. And honestly, I appreciate it too, because I feel like our conversations are more honest, and it's not in that procedural setting where you feel like you have to say yes. We get a lot of pre-procedure labs because it's the kind of mystique and trick to the system. We do a lot of invasive work through tiny, tiny, tiny puncture spots. So you can get into a lot of trouble really fast. So things we will check are your blood counts. Mostly we're looking to see if your platelets are good enough that they're gonna stick and clot. CMP, which is a comprehensive metabolic panel, I'm trying to see what your creatinine and your kidney function is so I can give you contrast if I need it. PTINR is telling me how well are you gonna heal after I try to stab you. And then nowadays, if you're gonna stay with me inpatient, we do have to do COVID screening. It's a whole thing, and it's not fun, the brain biopsy, but I'm hoping some of the newer rapid tests get accepted better so this isn't so brutal. And then what we're working into our workflow is updating your family on the phone. So one of the things I'm encouraging my patients to remind me and my staff to do is to take a phone number and text it to your family. That is to my preoperative area or my recovery area. So you can just check in, because we get lost and distracted all the time. So you just got to keep us honest. And this is kind of what we do all day because we have to keep ourselves entertained. Our intra-procedure team is huge. We are a very, 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 very social crew. So feel free to ask who's in the room with you, and any of us will introduce ourselves. Some of us are shyer than others. For my bigger cases, you have at least one, if not two technologists. Sometimes I have one, sometimes two nurses. Sometimes I have a medical student with me. Sometimes I have a fellow, I have a resident, there's always somebody there. We take a lot of time in the intraprocedural and the hospital-based setting with our setup and our cleaning. And it's really funny. Sometimes the biopsies will be super short and cleaning took us so long to set up, and the patients will just shake their head like, really, that all that rigmarole was for this? I'm like, sorry. We do our procedures under moderate conscious sedation most of the time. So I'll do a quick note on that because that in and of itself is difficult for everybody involved. Like I said, we can start with 3 team members. We can easily get up to 10. You can stop us anytime and ask us who we are. Biopsy systems. So the first 3 are a group that goes together, and the last one I put out there. So we are super, super blessed at with Dr. Rosenberg and his pathology team. If you give him a cell, he's going to give you a diagnosis. So you can do this small, tiny FNA, fine needle aspiration with the Chiba, and he really gives you amazing answers. And your bleeding risk is much less, but the volume of tissue you give isn't that much, and you can't do wonderful things like molecular testing and trying to figure out if they're target agents. So we all fall on the other end, where we're going to do what's called a core biopsy. Some people call it a true cut biopsy. These are all terms based on how the system was made. And what it is instead of taking an organ or a tissue or a mass and jabbing into it 4, 5, 6 times to get tissue, you take an outer straw that's metal and you put it in position. And then through that, you advance the inner biopsy gun and you change the angle to sample different areas. Just showing you a quick liver case, liver lesion, and this is under ultrasound guidance again. And then we're going to come in with the needle, remove the stylet, put the biopsy, and these are the small, tiny, tiny, tiny slivers of tissue that we give the pathologist. It's kind of mean, but this is all they get. They do a great job with it. Because you can only take so much out from our small, small accesses. And then to show you the ultrasound case of what we did, so the original picture here is the mass, and then as you'll see that comes in the other 2 pictures, I should have added arrows, that's the coaxial needle. And then through that, we advance the biopsy gun, again, torquing in different locations to get a sample and get a diagnosis. This is the CAT scan that I was showing that really shows you where the bone is, where the vessels are, and gives us a pre-guide before we go in there and do the ultrasound guided biopsy. The ultrasound is not good for staging the extent of disease. So I can't, from my ultrasound, tell your surgeon, hey, is the joint involved? Is the nerve involved? Is it encasing the artery? You can't give that level of information, and you really deserve that information before you go in and do a major surgery. So another major part of our day is giving access for chemotherapy. Access means what? It can be catheters external, catheters under the skin, but the goal here is to provide a small catheter, small tube that goes from either the arm or the neck down into the heart. So the chemotherapy goes to the system where you want it to and doesn't get lost in those small, small, small poor veins that you have in the peripheral system. The scarring that you feel in your veins from chemo is real. So I highly recommend as you go, if you have more cycles planned, upgrade to a kind of more robust line. The PICC lines, at least ours are purple. They usually kind of go under your forearm and they're irritating, makes showering difficult, especially in South Florida where it's always hot. But we work around it. You can keep those 10, 12 weeks. I kind of beg, I have a couple patients who like to try and keep them for a year. Like, at least come and let me change them because you deserve something new. The other catheter there, the pheresis or the trifusion or hemodialysis catheter, those are bigger catheters, but they're great. You can get a lot of therapy in really fast. You can get great blood draws, but again, something's hanging out outside. This is what they look like on x-ray. This is what we kind of looked at for in our pictures. This tiny little thing is the PICC line coming in from the arm. We access with ultrasound, and this is just showing a drape. So poor patient is kind of claustrophobic underneath our drape. We're trying to keep just the active area open. That's a small ultrasound probe in the physician's hand on the patient's chest. And what we're looking at on the other side is trying to put the needle right in. We usually like the vein on the right neck. It's straight down. It's a beautiful vein. It's kind. The left gets a little fun because you got to take a trick. But the reason why you're looking is you want to be in the vein. You don't really want to be in the artery. And there's other structures to avoid, but that's why you're asking for the guidance. Then during this procedure, there is some audience participation. So that little needle that I used before is tiny. It's 22 gauge. So imagine a little thicker than your fingernail. So you got to get up to a catheter size. So as you advance things, you slowly dilate up. And this is where things get a little interesting. Sorry, I should have mentioned that there's gross pictures, but you have to get the catheter into the vein. So in that point, we usually often ask the patient either take a small breath in, blow it all the way out and hold it out. Because if you're in the snoring phase of life and you take a deep breath in while I'm trying to put my catheter in, you take a big gulp of air with you. So this is where like I will often wake people up like, hey, I need your help for this. There's a story from one of my mentors where one of his patients was an opera singer. So he had him say E so to push the air out. And he also pushed the catheter out because he had so much pulmonary strength. It was ridiculous. Under your skin. So many people have ports, and that's what a port is. You're giving someone access to a little pocket that can go to a catheter and give the chemotherapy into the blood vessel, but it's underneath. So once it heals, this thing is you, it's part of you. But the most important thing about ports is know your port, because you're gonna know it better. Every time you get chemo or anything like that, you get the saline flush, you taste the saline flush. I know it irritates everybody, but I kind of like that you can tell me, hey, you're in place because I tasted that saline. If something doesn't feel right when someone's accessing your port, just say stop, we can check it. It's better to check it and find nothing wrong than for you to get chemo around the skin or the port not working well. You don't need that. We can always do one better. And this is what I mean by looking at your ports. This is not normal. This is clearly infected. A little pain and slow healing, this is okay. It's just taking time to heal. You probably heal like me. I'm a keloid former. It's just who I am. This is, again, not normal. So red, irritation, pus, catch me before any of that happens. That just means for whatever reason, the port's gotten infected, we need to get it out or we need to get you on antibiotics, but don't sit on these things and trust your instinct because you know yourself best. To show you what we look at for ports, so this is how the port looks from the x-ray. The CT is the little well of the two little owl's eyes, and then the catheter goes in the neck, up and around, and down into the heart to use. Again, there are many different access options. You get a lot of different treatments, and so they're all available to you. And when you come, you can very much so tell me, this is what I like, this is what I don't like. I have some patients who want their ports in different locations, what works for them. We once had a young man who's a football player, and he said, you're putting it on the sternum. Weirdest port I've ever placed, but that's what he wanted, and we made it work. Brief note on sedation. So again, know yourself. Some patients will tell us, doc, I only want local. This happens to me a lot. I used to cover the VA, so my vets don't want anything they could ever go through any experience before. And they'll do entire procedures that I personally couldn't do under local, and it's stressful for me because I feel brutal. Moderate sedation is my world, so it'll be like me and Evie here. It's just Naira attending a nurse and technologists bouncing around, and we do simple medications. Fentanyl is just for pain. It's short acting. I know it gets a lot of bad press, but my fentanyl is better than the one you get on the street, you know. Versat's supposed to make you forget, so that's something you give a little earlier. Versed is the medication that's the reason why we ask you to fast, because as you forget, you sometimes don't protect your airway, and if for some reason you have bad reflux or you vomit, you don't protect your airway, and that crud goes down into your lung, you're in a bad way. So that is what the fasting rules are. Classic fasting rules are anywhere from 6 to 8 hours. There are shorter ones. Things you want to avoid, especially in South Florida, is cafe con leche does not count as fasting, and orange juice is evil. If you need more anesthesia, you've been through too much, you can ask for monitored anesthesia care. This is that white medication, the propofol. I can't give it to you. We get experts for that, but that's going to mean an extra visit to meet the anesthesiologist and make sure it's safe to go that way. And then some of my procedures, especially ablations, you really need general anesthesia. This is full intubation. And even in the anesthesia world of general anesthesia, a lot of my procedures, I need full paralysis because I'm using them to make sure you give me those perfect breath holds that everything lines up millimeter by millimeter. And I'm pretty brutal with them about that. They know all my rules. So image-guided treatment. So we do everything as small as we can. One of the things we do a lot of, and a lot of this literature comes out of the liver cancer world, so we're trying to apply it different ways, is what's called intra-arterial therapy. So your cardiologist, when you have problems, will come in through an artery, sneak up and open up a blockage. We're trying to do the opposite. We're trying to steal an artery, sneak up into the organ or area that feeds the tumor and block off whatever's supplying it. Some areas you can't block, and you do what's just called chemoinfusion. This is we do with the osteosarcoma group preoperatively. Instead of giving the doxorubicin, or instead of giving the cisplatin systemically along with the doxorubicin, you can give it through a small infusion catheter and give it directly for different reasons and different protocols. Bland embolization, I do this a lot with my gastrointestinal stromal tumor patients to control liver disease. It is an old treatment and it's kind of funny, but it works great. Transarterial chemoembolization. In theory, it is wonderful. You take a little bead or you take a little kind of medication, you infuse the chemo in there, you leave the chemo to kind of leach out in the area in over the 10 to 14 days. Problem is, we can't make up our mind what chemos we want to give for different things. It's hard to do a clinical trial where I offer one patient no chemotherapy and another patient yes chemotherapy and call that some sort of correct medicine. And then with the drug-eluting beads, where you can really control the doses and have a lot of precision, we only offer 2 drugs so far. It's really disappointing, doxorubicin and irinotecan. Ideally, what the companies really need to work on are 2 things. One is a drug delivery system that's not a plastic that you keep with your life, that the plastic turns into actually like meshes away, so then the artery reopens over time. And 2, they got to get cisplatin on a bead. So that's there. Radioembolization goes back to what was discussed before. So this is kind of a form of brachytherapy. I'm just going to kind of show it. So on this bead, you're putting radiation on the bead or embedded in the bead. And there's 2 different companies, as always things out. And they have different features that we use. And we, at least at our institution, we have both. So we use them for whatever we think is best for our patient. This is great for liver tumors that are a little wild. So if it's more than 2 or 3 that you can't ablate, that you can't resect, you can actually treat a large segment of liver with the radiation. The radiation's beautiful. It's targeted, it sits in there, and it's there with you from 3 to 6 months. Problem is, because I'm depositing this in there, there's going to be some liver parenchyma treated as well. So you need a hefty volume of healthy liver before you kind of go down this route. But this is something a lot of us are really exploring and kind of expanding and treating like one-on-one as we get through there. The big group, if you ever want to investigate who's doing the coolest work on this right now, is Northwestern, and then Vancouver, and then UCLA has some beautiful things they're doing. So just to show you kind of what we look at. So we borrow a lot of times the artery in the groin. I do the artery in the wrist as well in my younger patients. And we're really just kind of sneaking around with a small catheter to get to the tumor. This is me drawing tumors and wires and arteries and things. So this is that same patient we saw in the beginning. And this is the arteriogram. So this is the artery. I kind of blurred it out. I should have done something better. And what we're going to do is infuse in here. And this is imaging that we read and we kind of guide ourselves, but it's very targeted. So instead of, instead of getting the patient head to toe with the chemo, you're starting with this catheter down here and just feeding what's downstream. And for some people, it really is the right thing. Ablation. This is really cool, and it's worth knowing a good ablationist. If you ask your surgeons or your med-oncs, they will find you people who do fun stuff, but you want someone who's done more than 2-3 fingers worth. It's got to be over 10 fingers. When you do ablation, you want to have a multidisciplinary review. We see all our cases in tumor board together, and we really talk about, is it going to work? Is it the right patient? Because sarcomas, we cheat, right? We use sarcoma as a garbage term for all these different things. So you need to find the right time, the right tumor, and the right location before you jump in here. We have a dedicated IR clinic because you should meet your provider and I should meet you, and we should talk about the risks and benefits before we just jump into a procedure. I will have you see my anesthesiologist because sometimes they find things that I totally forget to ask. And then, I don't trap them the day of. They're like, here, do the procedure. I do most of my procedures under general anesthesia. It's not fair. The procedures that I do, they take anywhere from 2 to 4 to 6 hours. I can't ask you to hold your breath and lay still for that long. I kind of like the old world where I get to keep everybody overnight and see them the next morning and make sure they do okay, and I don't give you the family, but I have a bunch of escape artists, they're great young patients and they want out 2 hours afterwards. So we argue about it, but I'm getting better at letting some people go home. And do come and see us again because we like to know how we did. And, if we didn't do well, we want to hear about it. So we usually see our patients 4 to 6 weeks. I have a funny group of patients who I meet them once. I do very little, but they like how I review their images. So they just come and see me every now and then. It's fun. It's nice. Different types of ablation. We have so many different things on the market. And the surgeons can talk to you about it too, because they do a lot of intraoperative ablation as well. Radiofrequency ablation used to be the go-to. This is a heat-based system. They're small needles with many times giving active heat in there. This is still used a lot in the spine. We're using it less and less in the liver. That's all going away to microwave ablation. Again, heat. A little faster, a little bigger than microwave ablation. I still kind of miss my old RF probes, but they don't make them anymore. Cryoablation is awesome, and I'll talk about that a little bit, especially in the sarcoma group, because here, especially with the palliative care providers who spoke today, is somewhere where you can give someone pain control, and that's invaluable. In the ablation world, what am I offering you? I don't really offer cure. I offer control. I offer chemotherapy holidays. But if somebody is an ablationist and they tell us, don't worry, I'll cure it, won't come back, they're not telling you the truth. Find somebody else. IRE, this is a lot of fun. Irreversible electroporation. This is electricity. The electricity, as it goes across tumor cells, it causes the cells themselves to form nanopores, and it sends some signal somewhere to say, hey, this cell is useless, get rid of it. There's no heat. That's a bit of a caveat too. If you over electroporate, you can generate heat. It's a long story, but this can take you to some very dangerous areas and do a good ablation. Chemical ablation is old and true. I use alcohol ablation in some strange occasions. Other people will do different acids and things like that. So in a good practitioner, this is an option as well. Just to show you, it's kind of boring. They're all probes and they do different things. So the microwave probe over here is a sagittal image on the liver. The RF probe in the middle is actually one of my partners putting a cannula and going to the spine to treat a bone tumor in a vertebral fracture. At the top is a picture that we'll kind of go over as a cryo picture, and then that smushy thing on top is a glove because I'm trying to freeze the tumor and not freeze the skin. And then those are a couple of crazy IRE probes that I did a few years back behind the esophagus, under the heart, next to the aorta. It takes you crazy places. The reason I want to take a minute to do cryoablation, and there's been a lot of studies on this. Matt Kalstrom's group over in the Mayo Clinic does some of the loveliest work. The other gentleman that I recommend all the sarcoma patients I meet go and meet in Atlanta, because we're so close, is Dr. Prologo and Emory, because they really push the envelope with this. But if something hurts, if you can find the bone edge or the muscle edge that's causing pain, you can give someone relief, and that is invaluable. And even if it's not complete relief and you can get someone off opioids or decrease the amount of opioids, this is important. Some people forget that we do this, and then we forget that we do this because we are greedy people too. We want all and cure and everything, but pain relief is a wonderful outcome. Just to show you a quick case that I had as a 42-year-old male with painful back mass, one of the fittest people I've ever met. This turned out to be a desmoid aggressive fibromatosis after biopsy. So we asked, can you do something? I don't really want surgery because it tends to come back on the edges. I don't really want radiation, which was an option, but he's like, all right, try. So I froze it, and we use, and this is what we're doing. On the probe, you are creating ice. That's the ice outside, not the ice inside. It's harder to see on my scan. And then you want to encompass this entire area. The reason it takes me long to get all this area, those ice balls are pretty small. They're not going to give me the 7 centimeters that I need. And that's a sagittal picture showing all the different probes of where we put it to try to catch a tail. And then you can see where the skin is. You've got to move the skin off and protect the skin. So this is a warm glove, and sometimes it's my warm hand trying to warm the skin, because the most common injury that I cause when I cryoablate is I cause some nice skin blisters and erythema. This is what the ice probes look outside. So that's a bunch of towels. This is a borrowed picture because mine are never this pretty. I don't get nice blue towels like this. And you can actually see the ice kind of forming on the outside. The probes are getting better. They're more insulated, but you have to be careful when you do the cryoablation, because if you put one of those ice probes, like just even the cabling on the skin, that can cause an injury in itself. It's kind of a long process. And every cryo treatment, once you have your probes in place, if you do it well, is on average of 36 minutes. And that's assuming you don't do pullbacks and do more coverage. So these are long procedures. But we get good responses. So kind of light bulb on and light bulb off, it's enhancing less, but more importantly, the area where he felt the lump and the pain felt soft, and the pain went away. And that is invaluable. And you have to keep watching to see if this thing comes back, because you can always treat again. You can ask your surgeon or your radiation oncologist to come and touch it up and things like that. But these are wonderful, rewarding procedures. They're just exhausting. So what I really recommend is become your own advocate and get information. So there's a lot of information out there. And as a group, sarcoma patients, I learn from you every time I meet you, because you just teach me a lot of different things. In the radiology world, this is really one of my favorite websites. It's, I think, a little basic, given all the knowledge you have and you bring to the table, but it's a good place to start. And it's a great resource when you have family members asking, what scan are you getting? You just go to it, you print it, you give them the whole PDF. Wonderful. Thank you. So if you have any questions, we can move there.
So great. Thank you, Dr. Venkat. That was a really great presentation. We are getting a little bit off of the timing, so I just wanted to chime in really quickly. What we'll do now is we'll take about 5 minutes of Q&A because I do see a lot of really great questions coming in. And then we'll go into the nonprofit session and we'll start with Dr. Cava, and then I'll be last. And then there was a question about the prizes that Dr. D'Amato so generously provided. And I just want to share that if you complete the survey, you do get 1 entry into the drawing. And then for each $25 donation to the Alliance, you get an additional entry. So I put the link there in the chat, and the drawing will happen on Friday, October 9th. So we'll go to questions now. Thank you.
Okay, great. Okay, so, okay, let's see. What is the, let's see. Okay, why do radiologists use cryo and IRE? We know a child that is in complete remission after using IRE. So maybe what's the difference between cryo and IRE? Or is that too common?
No, that's good. IRE is great. The way IRE works is you have to put lots of probes to make an ablation zone, and you have to keep them so they fire within 2.2 centimeters, but not more than 1 centimeter close together. So when you build an IRE ablation zone, you have to really take your time. So they're really intense procedures. Then there's the component of what you're putting the patient through. So I tell all my IRE patients, because I'm giving you electricity, I can give you a bad arrhythmia. We gate, and sorry, I should have kept those slides and I cut them out this time because it felt long, with the heart. And if I see the arrhythmia and I can control it, we keep going. If I see the arrhythmia and we can't control it, we are stopping. So some of those patients where I'm a little worried that they're gonna have that kind of arrhythmia, I'll tell them like, okay, we can either decide we're gonna stop or I can switch to a different ablation modality. A lot of times you can't do that because if I've pulled out the nanoknife and the IRE probes, I'm playing in a very, very critical space. And there are structures around that I don't want them exposed to thermal injury. Cryo, again, also can take you to great places. The problem with cryo comes is the beauty and the bit of interest of the ice ball. So when you build the ice, when I showed that picture, the outer 5 millimeters is kind of silly ice. It's cold, but it's not cold enough to actually cause tissue death. It's the worst kind of ice. It's cold enough to cause injury to your nice stuff next to it, but it's not cold enough to treat. So you really have to kind of move critical structures out of the area. I bring cryo out whenever something's over 5 centimeters because you need to build a lot of ice. You have to go big. Stage procedures, when you do thermal ablations, it doesn't really make sense. I'm kind of an all or nothing sort of girl. Some tumor types, you can do things in pieces, but remember, when you're treating only part, you're leaving a lot in there. And if you're gonna go that route, it really has to be multidisciplinary and it has to be honest. Why does everyone not do it? So this goes back to like why I'm here and what I'm doing here. My boss supports what I do. So if I do nothing but one case all day long, it is okay. In the real world, no one can support that because it's very indulgent. But we're a big academic cancer center, so you know they spoil me.
So here's compare ablation, like so for lung mets, I think we have actually 2 questions that I could probably combine into one.
Okay.
How do we choose between doing SBRT for pulmonary mets, ablation, or chemotherapy? You know, obviously I can talk about the chemotherapy portion of it and that, you know, but we'll get Dr. Venkat and then Dr. Hakimian's opinions as well. When I think the main thing is that we presented at the sarcoma conference, right? We want to get everybody's opinion to see. But I do have a question between Dr. Hakimian and Dr. Venkat. When is it better to do SBRT versus ablation in lung lesions? Maybe we'll go with Dr. Hagen. We can have a little debate for a 1-minute debate. Okay. Maybe we'll start with Dr. Hakimian. Oh, you know what? I think that his audio is a
Oh, we got
problem.
me again. No, so
Okay.
personally,
Well,
to
then
me,
obviously
sarcoma wall-
ablation's better. No kidding.
no, not really, not at all. So
No, no kidding.
there are places that scare me. I'm pretty
I know.
aggressive, but lung, and you know this because you send me these beautiful lung cases and I find a way to say no all the time. So if you've been through a lot of procedures, the SBRT is gorgeous, it's efficacious. A lot of times they do it nowadays. It's not like the old radiation where they're radiating from head to, you know, abdomen. No, they're focused, beautiful drawings. And I tease my sister about doing her drawings and turning the dial. But 5 sessions, no needles, no pneumothorax, no hemothorax, no bleeding. So I am a big fan of SBRT in the lung because they do a wonderful, wonderful job. Some patients, you know, if it's not a good one for SBRT, they've already done the radiation before. If they're small, peripheral, less than 3 and less than 3 centimeters, I can consider ablation. But again, remember, and I showed you those cryo probes. These are pretty big needles and you are puncturing the lung, and pneumothorax is like air getting around the lung and needing a chest tube and hanging out with me is pretty much expected. If I get away without that, that's fine. So I don't like really any procedure where, you know, I have to do that kind of thing. Anyone can tell you I hide from lung biopsies too. But the lung's not a great fun place to play. In Europe, they love doing lung ablations, and they'll do 2, 3 at a time and things like that. It's interesting. I freak my anesthesiologist too when I tell them like what I've signed them up for that day. I'm like, really, do we have to do lung? Like, we signed up for it.
So it sounds like SBRT. Oh, sorry. We'll look at Dr. Hakimian.
Yeah, so SBRT is actually a good way of doing the radiation treatment. It also has its own limitations. So if you're dealing with the small lesions, it's actually great. If you're dealing with the peripheral lesion, it's great. Once the tumor starts getting bigger and you have to treat a bigger volume, understand that a lot of dose of radiation can also get into the normal lung tissue. So we look at the volume of lung that's getting 20 gray as our landmark. If it's exceeding that much, more than 20% of the lung or 30% of the lung, then I think it's something that we try to actually avoid. So it works great, but it has its own limitation. For like 10 centimeter lesion, I probably wouldn't use that. For 4 or 5 centimeter lesion, that's I think the upper end of where I would draw the line.
It seems like for the lung, probably SBRT may be favored a little bit. I mean, of course, it's case by case, but maybe SBRT may be favored a little bit more than the ablation. But for the liver, it seems like it's the opposite. Is that true, or?
So central part of the liver, we usually don't treat those anyway. But usually with the liver, there are multiple metastatic diseases. For small lesions in the periphery, I think that's something that we can consider, although it's not as great of a result as interventional.
And then,
I was hoping that you say chemotherapy is effective.
Well, yeah, I mean, you know, of course, you know, if it's multiple lesions, we try to do the chemotherapy or systemic therapy because either radiation or ablation targets 1 or 2, whereas the chemotherapy, you know, targets all of them. But sometimes patients are on treatment and it's working in the majority. They may have 10 or 20 spots in the lungs, and maybe it's working on all of them, and then 1 or 2 are growing, and that's where we can work in combination, where we can keep the patient on treatment, but maybe zap 1 or 2 of the ones that aren't behaving. So that's why it's.
I also want to throw in our thoracic surgeons sometimes actually operate on these. Sarcoma is one of the few areas that actually have shown benefit in terms of metastatectomy, removing the metastasis. May help overall survival.
Okay, and let's see. How, as patients and caregivers, know that the scan facility is using the machines that are effective for LMS, and how can we tell that, in particularly the minimum resolution for scanners used for a specific scan? It's a pretty technical question.
No, it's like a very, very, very good question. The way I kind of tell everybody, because like we're a referral center, is bring your CD and let me read it. And a lot of my patients are very cognizant. We read the scans together and then we discuss, okay, where did you have that one done? That one's really good. Go back there. We don't make everybody have our scans here. The way to kind of know is you can ask the technologist and they're going to tell you. The CT scanners these days are incredible. This becomes more of a question with the MR scanners that you're getting. And even if the scanner itself is good, it's the protocol. So the person who decides the phases you're going to get, when you're going to get the contrast, what settings are they going to put, that makes a difference as well, because you can have a great machine and still not know how to use it. So make someone look at the scans and tell you that you trust. Have your oncologist pop it in there and say, hey, is this a good scan? I have a couple patients, they even know they're diagnostic radiologists. And when I order their scan for them, like I have one patient in Arkansas who's awesome. He's taught me to put that individual, her name in every time. So she reads all his scans and I love it because I feel like I almost know her and we've never met, but because it's one person who knows him well.
And then what is the ideal type of scan to monitor METs for uterine leiomyosarcoma?
That's for you, man.
Okay, that would be a CT scan. As Dr. Venkat said, the protocols now do have lower doses of radiation than in the past. And then if there is a question about something new popping up on the scan, then that's when a PET scan can be helpful to show, is there activity there? So we're always comparing with previous scans, is making sure that there's nothing new, but still CAT scan is standard unless you have renal insufficiency and can't get the contrast, then we would go with MRIs. And then this says, how can radiologists see highly radiated pelvic bone using scans if they're still in remission? Like how long does it take for the bones to start looking normal? Or can it, can it be ever look normal? I don't know if that's a question for you, Dr. Venkat, or if you can maybe phone a friend for that. Maybe we'll have to get back to you. That seems like a hard question.
Back to that one.
Okay, maybe we'll go back to that one. Okay. Okay. All right. Well, I just got a text that I have to wrap this up. Anyways, okay. All right. Well, there's some other questions, but we'll ask Dr. Venkat and Dr. Hakimian and anybody else on the panel to those questions. And we'll move on. Thank you so much.
Thank you.
Hakimian, Dr. Venkat, and hopefully everyone now knows the difference between a interventional radiologist and a radiation oncologist. Okay.
We're all friends.
That's a good thing. Thank you all. So now we're going to go into the nonprofit session, which is going to be set up just a little bit different than the physician speakers session. This is going to be a little bit faster with the speakers. We'll have about 8 minutes for each presenter to present their topic, and then a couple of minutes for each question and answer period. So I'm really pleased to introduce one of my nonprofit colleagues. This is Dr. Shannon Cava. She's with the Cancer Support Community. And Dr. Cava is the Chief Clinical Officer and Director of Programs and Research with the CSC Los Angeles. This is the founding affiliate of the largest professionally led nonprofit network of cancer support worldwide. CSC is dedicated to ensuring that all people impacted by cancer are empowered by knowledge, strengthened by action, and sustained by community. So CSC LA provides free of charge psychosocial support in the form of support groups, healthy lifestyle classes, educational talks, and more. And all the programs and services are currently offered online. So welcome, Dr. Cava.
Hello, and thank you. I do want to give a special thanks to you, Alyssa, and to Charles Massey for the invitation to participate today. And I think I'll go ahead and get my slides up here and show you a little bit about our community. Okay. Are you able to see these okay?
Yes.
Okay, great. So Cancer Support Community is a worldwide organization. It's a nonprofit that offers social and emotional support for individuals and families that are facing cancer. We are at the Los Angeles location, myself and our colleagues, and work out of West Los Angeles and currently online. So I'll go through these slides. This is a little bit of what our community looks like if you were able to open, our space today. When we are safely able to do so, we look forward to inviting everyone in. And again, it's just a very open community feel, and there's no right or wrong way on how to use our services. We really look to somebody that's coming in that's looking for support on how we can best help them through their cancer treatment or as a caregiver. And again, like I said, this is just our national reach. We also have 4 international offices. So if you're not in Los Angeles and you're watching this today, you can go to cancersupportcommunity.org, and there's a list of locations. So you're hopefully able to find one near you. And at the end of this deck, I'll also show you a helpline so you can get connected with support in your area. So all of our cancer support community locations, including ours in LA, offer what we call like our 5 core components of care. So these are the pillars, and the areas here are group support and counseling. So this is the real social and emotional connection, meeting with others that might have a similar diagnosis or have had treatment that you're going into. So it's a good place to just make those connections. Our counseling is a brief model. So we offer about 8 individual sessions to somebody, and this is also at no cost. Not all of the affiliates have the same individual counseling, so you can check and see if there's something like that local to you. But we also have a children, teen, and family program, and this is for anyone that is maybe a parent or a loved one has a diagnosis and there's children in the family. We also work with pediatric diagnoses and have support for siblings. Educational workshops I'll go a little deeper into, and this is really just to provide information and education. We invite topics across, general to cancer, self-care. We look more specifically at individual cancer diagnoses. Nutrition is a big one. So we really try to fill that need and that gap from what our members recognize that they'd like to learn about. And then we have healthy lifestyle classes like yoga and Tai Chi, Qigong, a lot of mindfulness classes. We have some Zumba and dance. So these are also all available online currently. And then we do social activities. So it's not about cancer, it's just about connection. So to give a little bit more of an explanation, at our Los Angeles affiliate, this is what our current calendar looks like just for the support groups. So we have groups that are across diagnoses. We call those our dedicated groups or participant groups. We have groups that are specific to caregivers of any type of cancer, person that they love. And that's inclusive of all different dyads. You could be caring for a partner, a spouse. You could be caring for an adult child or a pediatric child. You could be caring for your adult parent. So open to everyone. And then we have groups that are specific to diagnoses. We have some that are specific to just population. We have a young adult group that's really growing, and it's doing really well, especially now online. And we have some groups that are specific to even a living alone with cancer. So somebody that might not be living with a caregiver that wants some additional connection. And then I did want to share a little bit about our education here. So we're able to offer our presentations online. Previously, they were in that large community room that I showed you. And we also videotape our lectures and are able to either live stream, and we have a video library on our website. So if you go to cancersupportla.org, that's our specific site. And there's a video library that you can connect with and see some of our past videos. And again, they're being posted regularly as well. The Cancer Support Helpline, I did want to make sure I highlighted this. So this is available to anybody really anywhere. The hours on the Pacific Coast are 6 a.m. to 6 p.m. and they've actually opened since COVID weekend hours. And I believe they're very consistent with that. So they're open on Saturday and Sunday. They have bilingual support. The individuals that answer the call are either licensed mental health professionals, so they can help you if there's a need that's a bit more acute that you're looking for support or connection in. There's also resource specialists. So if it's just, you know, I'm looking for something to give me some support with my finances, or maybe there's something legal, or, you know, anything under the sun, including organizations like Sarcoma Alliance, where they're looking for more information specific to a diagnosis. So that number is here. It's 1-888-793-9355. And that's a great place to get started. And it's also a location, if you call them, they can get you connected with local support. That's more in person, or at least online, that will hope to be in person again soon. And then this is just our program team. So this was a very abbreviated version of what we have as an online orientation. So somebody that's interested in our services that might come in or get connected with us via email or through our website, we'll invite them to meet with somebody on staff that tells them about everything that we do with more detail, and then really helps get connected to whatever it is that that person is interested in doing. And this is just so you can see our faces. I'm on there. Larissa Montalvo is our program coordinator. She's a great first point of contact to get connected with our services. Michal Bick is also the individual that's leading our orientations. So we know now there's a lot of phone, right, and a lot of email, but we try to do as much as we can to make that connection, even if we can't be in person. So that is the end of my deck, and I can go ahead and take questions. I know this was a brief little sampling of what we do, so I appreciate your time and your invitation.
Great, thank you, Dr. Cava. Does anyone have any questions? Or shall we move on to Imerman Angels? Let's see. Imerman Angels. Okay, great. Thank you very much. Really appreciate your partnership.
Thank you so much. Bye-bye.
Great. So our next speaker is Jackie Herigodt. She's from Imerman Angels. Jackie is the Director of Programs and Outreach with Imerman Angels. Jackie has been a caregiver to several loved ones with cancer, including her mother, who lost her battle with lung cancer in 2004. These experiences fuel her passion for the Imerman Angels mission. Jackie has been with the Imerman Angels since 2012. In her current role as Director of Programs and Outreach, she oversees the Mentor Angel training process, the matches made between Mentor Angels and support seekers in the organization's outreach efforts. So, welcome, Jackie.
Thank you so much. I'm excited to be here. Thank you, Alyssa. Thank you, Charles, like I said, and thank you to all the specialists. Oh my goodness. Watching this gives me so much hope. Like before watching this, it's just like I'm always in my world of emotion. And, you know, I hear some of the stories and the treatments, but like after watching these doctors and these specialists, I'm so excited for the sarcoma world. So thank you, Dr. Venkat. Amazing. Like your sense of humor and your realism and your genuine. I just love that. So I appreciate you greatly for all the work you guys are all doing. So thank you. So I'm going to share my screen. Give me 1 second. There we go. All right. Can you guys see now?
Yes, we can. Thanks, Jackie.
No worries. Okay, so again, this is me and why Imerman Angels is important, or why this topic is important to me. So I've been a caregiver several times to people, unfortunately, that I have lost to cancer. And so prior to Imerman Angels, I just thought that that's what happened. You know, people got diagnosed and that was the end. So I lost my mom, my aunt, my grandmother to cancer, and it's really hard to deal with, but what I was able to do was move forward and learn about Imerman Angels, where they were able to provide me the understanding that that's not always the case. And I had met so many survivors and, have just been so blessed with meeting, other organizations such as Alyssa and, CSC. We work with them all the time as well, and just other organizations to really partner up. And really get the awareness out about being a survivor and all that it takes in the cancer world to really move forward. So it is about the treatments, obviously, but there's also this emotional perspective. And so if you have a positive outlook, it does help with your treatments. And if you're a caregiver, it could really help you as well if you have somebody there to help support you. So when I learned about Imerman Angels, it was just amazing, because I knew that I did not have to always look at my experiences as a negative. I knew I could take those negative experiences and turn them into something positive. So at Imerman Angels, we envision a world where cancer is not a solitary experience. And so what that means is you have somebody there. There are people there that have gone through this, and that's the key. Now, could be that you're interested right now, you're watching this, and you've just been diagnosed with the sarcoma, right? And so you want to talk to somebody else that's had that particular experience. Well, we could connect you, because we're global, to somebody else that had that particular experience. What I like to highlight is it's not only about the diagnosis. And I am sure that you're watching this understanding that cancer is way more than that. You have other things going on. You could be a single mom going through this, and you just want to know, how do I talk to my kids? How did you talk to your kids about this? You could be, a single dad. You could be somebody going through a divorce and then also dealing with a cancer diagnosis. So our job at Imerman Angels is to find you your peer to talk to, your one person that understands what you're going through, and provide you comfort and understanding to what we say is cancer fighters, survivors, caregivers, and also previvors that are going through the same experience. So Imerman Angels has been around for quite a while now. And we started with a very small amount of people. Johnny Imerman's the founder. He had testicular cancer. He decided out of the hospital room that he was in that he wanted to connect with somebody else that had testicular cancer. He had his fantastic mom, who's adorable. I'd love if she'd adopt me. But she could not answer what it would be like to date after testicular cancer. So he wanted to talk to someone else that had been there, done that. So he, said this should exist. And so he created this amazing organization back in 2006. And now fast forwarding, we're almost at 12,000 mentors around the world. These are volunteers that want to give back. They're taking their experiences and they're sharing them with someone else. So if there's somebody watching this and you've already been diagnosed, or you've been a caregiver and you just feel like, what do I do next? We could be your what's next. Look into our organization, and please, think about supporting others, because I can tell you from personal experience that it is very therapeutic to kind of throw that rope back and help support somebody else, to help them figure out what could be the next thing that they need to do, what could be beneficial, what do you wish that somebody would have told you. So we're helping, with 12,000 mentors, and we're not only helping in the sarcoma world, which obviously that's why I'm here, and we have this great partnership with Sarcoma Alliance, but we also help with other cancer types as well, and again, around the world. So the importance here is that we work with Sarcoma Alliance, thankfully to Alyssa, and we are matching people right here in the network. So why would you want to reach out to Imerman Angels? It's because maybe you feel like nobody else has gone through the experience that you have. Well, I'm telling you that I bet you there's somebody that has, and we will do our darndest to find that person for you. to get you connected. And sometimes it's just one or two conversations that you just want to have with someone else. Or maybe you don't want to talk on the phone. Maybe you just want to email. Maybe you just want to text. Well, we can do that. And so that's how we chat with you and find out what is important to you in this relationship, and what questions do you have that you want to hear from someone else that's been there, done that, and then we connect you to that person. So we have lots of stories to share, but the point is that over the years we found that there are things that keep you similar to other people, and then there's things that divide you, right? So what we do is we created this database and we write down everything and note it. And when somebody comes our way that said something that, matches somebody else, we go ahead and get them connected. Our matches usually take about 3 to 5 business days, depending on what the request is. So to try to keep you from waiting. So I wanted to just dive down into some of the particular sarcoma numbers. I know Alyssa always likes the numbers. So I did put some together. We have 723 mentor angels specifically as a whole, and 574 survivors themselves. 40 just this year, and 15 this year have said they've come through the Sarcoma Alliance. So we're always looking for more mentors. We're always looking for caregiver mentors as well. So there's probably caregivers on this call that think that they, have nothing to add. Believe me, you do. We always need your support. So please come and become a mentor angel with us. We would love that. So you can either register on the phone, or you can do it on our website, and just takes 1 or 2 conversations. We do train you if you're becoming a mentor, or we just find out what you need. Our database is filled with all this information, and we'll ask you these questions, and we make it as easy as possible. And then we'll just stay in contact with you over the time of the connection. I did provide, hopefully this is easiest, what we found working remotely is that texting seems to be the way that everybody wants to communicate right now. So if you text 515-51555, sorry. And if you want to get support, you press get support. If you want to become a mentor, you would text survivor. So those are the 2 options there if you want to text, or if you want to go to our website, it's just www.imermanangels.org. Again, www.imermanangels.org. And that's what I have for you today. So thank you so much.
Thank you so much, Jackie. That was great. We really enjoyed our partnership with Imerman Angels. It is new this year. We had historically provided the peer-to-peer program, and realized that with partnering with Imerman Angels, we could reach hundreds of people and really provide the mentorship and connection, because it's not about cancer, it's about connection with these resources. So thank you so much. I have a question here that came in. Is Imerman Angels only for adults? And also, is it for children of cancer patients as well? So good questions.
Thank you. Yeah. So no, we have all ages. So all ages, all stages, everywhere in the world. And as far as children of cancer fighters, yes. So if somebody's taking care of their parent that has a cancer, then yes, they can come. As a caregiver, we know that balancing your life and somebody else's is really essential. So of course, we would want to connect you as well.
Great, thank you. I think that was the only question. There is a question for me, it looks like. Where can we find the evaluation form to fill out? So the evaluation forms will be emailed to each of the registered attendees following the program, and that's where you will actually complete the survey. Great, and then someone says thank you, that they will connect with you. Great, Jackie. So thank you, Jackie. Awesome. Really appreciate you being here. I am going to round out this session. So let me go ahead and share my screen. Okay. Okay. So I just wanted to take some time to revisit some of the information about the Alliance in case, especially if folks are new to the sarcoma world and if you're facing a new diagnosis, especially, but we have been around for about 21 years at this point. So I just wanted to explore a little bit and just educate folks on, you know, the early days, a little bit of history, our mission and leadership, what we do, some of our programs and initiatives, and then how to really get involved, and a little bit about sarcoma awareness. And then we'll see if we have a couple of minutes for questions, but I will be around at the end of today's session if you do have questions about the Alliance, and of course you can always contact us. So for the early days, as I said, we've been established for 21 years. We're really the only nationwide nonprofit that provides guidance, support, and education to everyone affected by sarcoma. And I like what Dr. Cava said earlier. It's not about cancer, it's about connection. And we really want to connect the dots for people within the sarcoma space. So we don't really raise funds for research, which may help people in the future. Instead, our funds really help people affected by sarcoma right now. Pictured here, I just wanted to show you, this is the very first sarcoma support group from 2001 that the Sarcoma Alliance organized. And many of you might know Dave Murphy, who's there in the bottom left. So he has continued to be an active participant, even within the cancer support community groups too. So once again, our mission of the Sarcoma Alliance, we're a 501c3 public charity nonprofit that really serves as a resource for sarcoma patients, their loved ones, survivors, by providing them with improved access to care, and then the guidance, support, and education along their cancer journeys. So now look how far we've come. We still have the very same mission, but we've had an expansion in our programming. And this is a report infographic from last year. And then for the next part of this, I just wanted to speak briefly about what exactly we do. And of course, there's lots of information on our website that you can revisit and also contact us. So we inform, support, and connect those facing sarcoma diagnosis with a variety of resources. We have our quarterly newsletter, which provides news and updates about upcoming events and all kinds of interesting info. We have our social media platforms, including our Facebook news page, Twitter account, Instagram, and of course, YouTube, where these presentations and events from this weekend will be posted. We have thousands of community supporters that engage with us through these platforms. Then we have our website resources, which hosts a lot of information on sarcoma, everything from verified sarcoma centers to financial and social resources. And then finally, we have our educational webinars. This is new this year, and it provides opportunities really for the community members to learn and engage with sarcoma experts. So next, I wanted to talk a little bit about support initiatives. Of course, we have our assistance grants, which is what we're known for a lot of the time. It's one of our signature programs where we reimburse cost of second opinions, things like travel, co-pays, lodging. This year, we are, of course, incorporating, and for the foreseeable future, reimbursement of costs related to virtual second opinions. And we reimburse up to $500. In 2019, we administered 84 grants. And then you just heard from Jackie about the peer-to-peer program. For over 15 years, we organized that, but now we have our partnership with Imerman Angels. And then for resource navigation, we receive over 2,000 requests each year for assistance. And we provide assistance in accessing appropriate health, social, and financial programs and services. For connection, we have our Facebook support group, which many of you probably learned about this exchange from that support group. We have about 11,000 members who are very active, and it really gives people an opportunity to connect with those who are facing similar experiences and diagnoses. We have the Sarcoma Exchange. This year, of course, we're hosting it online, and in the future, it'll probably be a hybrid. And it really provides an opportunity for folks to connect with other survivors, loved ones who are caregiving for someone affected by sarcoma or sarcoma patients. And then, of course, our social media accounts provide another platform for folks to connect and engage. So for this last piece, I just wanted to briefly touch on how to really get involved. And specifically, most people hopefully know that July is Sarcoma Awareness Month. We celebrate it in July, of course, but we also want to make sure that folks are aware year-round. We're actually launching a PSA campaign that is taking place November 1st through January 31st. So stay tuned and please share with your friends, your family, your colleagues to help raise awareness about sarcoma. You can also get involved with our organization by donating online, hosting your own fundraiser, even on Facebook or volunteering. We're always looking for people to share their stories, so please feel free to reach out to us to share your story, either start a support group in your own area, write an educational article, compile resources, even serve in the leadership capacity. We are looking for volunteers to help us. And please don't hesitate, if you have a creative idea, please feel free to share it with me. So this is new this year as well. So, you know, be safe, wear a mask. We had these designed by a board member, Kevin Plotner. And these are available on our shop. So this is an easy way to raise awareness. And then I just wanted to summarize with some of the testimonials here and show you these. You know, I do want to make sure that folks feel supported, not only through the journey, but for the lifetime if you have been affected by sarcoma. So we're here. You can contact me directly anytime. I'm at aodriscoll@sarcomaalliance.org. Here's the phone number and our website. So I just want to stop sharing. And if you have questions, I'll take them now. Okay. Let's see.
See, there's one question from the chat about regarding financial support for second opinion. Could you please provide the contact information or detailed information?
So what I'll do is I will post the link to the application, and then you can always call our office at that number if you have questions. So let me do that now. So that's a great question.
And there was also a question about why the Facebook group is public and not private.
So I think, you know, it goes without saying that basically everything on Facebook can be considered public if you're writing on it. So I think we, you know, historically that has been, you know, a public group where we do ask members to answer questions to make sure that we don't have any bad actors.
And it is, you know, it is monitored. And the thing is, if we made it private, then it may be very difficult for members to join. And so we want as many people on there as possible to help out others. So unfortunately with the internet, nothing is ever private anyways. So I think that's, you know, so I don't think we've had any issues with people, you know, their privacy being, you know, affected.
This is Suzanne.
Yeah, I can hear you.
Oh, you can. Okay, sorry.
And on that?
I just wanted to say that I know some people who join the support group use a pseudonym or an alternate group, an alternate name to so that like family or friends, if they don't want them to see the information, don't see it. So that's always an option.
Great. Thank you. And that was Suzanne Schwartz. She's on our board of directors and the work group committee lead and director for this. So thank you, Suzanne. Yeah.
Thanks, Alyssa. Are there any more questions from anyone, or should we move on to Diana?
I think we're ready to move on to Diana. Yeah.
Okay, so I've got Diana's slide up here, and I'm going to quickly read her bio. Diana Torres, MPH-RD CSO, attended the School of Public Health at Loma Linda University, earning her MPH in nutrition. She completed a Bachelor of Arts in Business Management from Claremont McKenna College and Bachelor of Science in Bioengineering from University of California, Berkeley. In 2014, she joined the Patient and Family Support Program at the Cedars-Sinai Samuel Ocean Cancer Center. Diana helps patients make mealtime decisions and food choices with respect to their treatments. She wants individuals to understand exactly what they're eating, what benefits that food offers, how it interacts with medications and supplements, and treatment-related side effects. So without further ado, I will stop sharing my screen, and Diana, over to you. Thanks for joining us.
Yes, thank you for the introduction. And thank you to the Sarcoma Alliance for inviting me to the exchange. I'm pulling up my slides now. Hopefully you see them. And there is a little bit of a delay, but there you go. So today I want to go ahead and get right into my slides and presentation and discuss health promoting food choices and habits and the typical questions surrounding somebody dealing with a sarcoma diagnosis. And hopefully we have a few moments to address any of your additional questions. To first start with a talk about the general healthful diet, I like to talk about plant-forward eating. And this doesn't mean that you have to eat vegan with a certain diagnosis. It just means we want to try to include more fresh produce, more high fiber vegetables and fruits and whole grains. And I like to call your attention to the graphic on the right side. We don't need to be measuring everything, but if you look at this graphic and use it as a visual guide when planning your meals, where half of your plate is a fruit or a vegetable and a quarter of is your lean protein source and the other quarter is your high fiber or carbohydrate source with your healthy fats used sparingly. That's what we think of as an ideal meal, and that not every meal has to look like this because we do know there are variations in eating habits and cultures, but you are asked to think of this as a guide. And this is from the AICR, the New American Plate graphic, to talk a little bit more about portions and how we want eating habits to just be a little bit more intuitive into our life. I want you to use this slide to think of common portions. And hopefully you'll have time to reflect and look back on it and compare to what your choices are. And you can maybe take a screen grab and save it for later. Under some situations, it is a good idea to look at your labels. And this is a new updated label that you should start seeing on your grocery stores. And it reflects more typical serving sizes. And I call attention to the calorie content, to the specific foods that we want to try and maybe limiting more of our saturated fat, our sodium, and our added sugars, which is now a new line to include exactly what portion of the food source is coming from an added sugar, and try to have more of your dietary fiber, maybe your vitamin D,
your calcium, your iron, and your potassium. So let's talk about some food groups and what foods we want to include more of. And we want to think of your plate as being colorful, full of fruits and vegetables, that going back to the graphic, half of your food coming from produce. And on this slide is a helpful handout from the environmental working group, and it looks at the content of your produce, commonly consumed produce, and it looks at the pesticide exposure. So a lot of people will ask if our foods need to be organic, and we take the position that food doesn't have to be organic, but if you choose to have organic food and you have access to organic choices, you want to stick with the foods under the Dirty Dozen list as the organic choices. And the foods that are in the Clean 15 list do not absorb as much of the pesticide content. And so there's no pesticide exposure difference in getting the conventional versus the organically grown fruit. A lot of people also will take the position or have the question about whether all produce or all food needs to be consumed raw. And I want to encourage people to have a variety of meal preparations, because the different nutrients that are in the produce that I'd like you to eat, it can be absorbed differently based on how the food is prepared. So there may be some benefit to consuming raw fruits and vegetables. You'll get more of the fiber, you'll get more of the vitamin C and the B vitamins, but I also encourage you to choose more cooked greens or baked or steamed or stir-fried produce, because you'll get more of the fat-soluble vitamins and the minerals, and especially important to think about the minerals like calcium, zinc, selenium, iron. I also want to take this opportunity to talk about how we do encourage consumption of fruit in addition to vegetables. Sometimes when I see someone in consultation for the first time, they come with the concern that you can't have anything that is sweet, and that is not the case. We do want you to have a good variety of foods and take advantage of all the nutrients that are available. I like this next slide, and hopefully you can refer to it later, but like I initially said when talking about fruits and vegetables, we want to eat foods with a lot of color. We want your plate to be colorful. And so all of these different fruits or vegetables are encouraged. A serving size of something like broccoli is half a cup. A medium fruit is the serving size generally of things like apples or oranges. And if we're talking about a leafy green, then a cup is a serving. So you can see that if you are choosing a variety of vegetables and maybe doing a variety of preparations, you can meet that goal of hitting 5 servings within your daily consumption. I am moving through this a little quickly because I want to be aware of your time, but in our next discussion of talking about general healthful eating and thinking back to that American plate, let's think about our protein needs. And we do know that protein is very important for individuals with a diagnosis, maybe preparing for surgery or going through chemotherapy, in that our body has higher protein needs. The general of having at least 0.8 grams per kilogram of body weight is just the starting point. And often people do not get that amount, or they think they need to cut out all of their protein sources because of a diagnosis. Your average person can need about 45 to 55 grams of protein per day, but that again is a starting point. In terms of red meat, we want you to think of, as a general guide, limiting consumption to 18 cooked ounces per week, but that guideline can be loosened depending on what is planned in your treatment. And somebody that maybe has more protein needs, then we don't want you to feel like you're hamstrung by that 18 cooked ounces. And we want you to try and have more variety, more protein choices to optimize your nutrition for your treatment plan. I'm going to skip the last bullet point so that I can just show the appropriate slides with it. Often we hear about fish consumption, and this is a helpful slide to look at why fish is beneficial, but also what we want to use as a guide on how to avoid maybe higher mercury fish. So we do recommend at least 8 cooked ounces of fish on a weekly basis to provide for that essential fatty acid, the EHA, the DHA and the EPA. Our high omega-3 fish and low mercury fish we'll see are on the left side. Let's call attention to the salmon, sardines, mussels, rainbow trout, Atlantic mackerel, and cod. And the good omega-3 sources that are also low in mercury would be more things like herring, pollock, and oysters. 2 good resources to look at in the future would be the seafoodwatch.org and your fishadvisoryonline.epa.gov to get more specific fish information to talk about mercury exposure. So to round out the discussion on protein, I like having this graphic up, and we want to think about how can we include maybe more plant proteins in our diet. We want to consider that not all plant proteins are considered complete, meaning they don't have the 9 essential amino acids that our body can't create. In general, the beans will lack methionine, and our grains and seeds will lack lysine. But if you look, there are good combinations of foods that you can include, and you don't have to have a complete protein within the same meal. You just want to think that you have good variety throughout the day, throughout the week. One thing I want to talk about with this slide is you also want to pay attention to your typical portions. So yes, 3 tablespoons of spirulina will give you 12 grams of protein, but often we're not going to be consuming those 3 tablespoons at one time or even in one day. I think the more common servings of spirulina is maybe closer to half a teaspoon or a teaspoon. So then you would get much less protein, even though it has good protein content. Same thing on this slide with flaxseed. It says 3 tablespoons to give you 6 to 8 grams of protein, and generally people will do more of a 1 tablespoon. Let's also look at the plant protein content for potatoes compared to black beans. In 1 large potato compared to 1/2 cup of black beans, you're getting the same amount of protein, but not listed on this slide is the other nutritional content. And so in that 1 large potato, even though it'll give you 8 grams of protein, it's going to be closer to 300 calories versus a 1/2 cup of black beans giving you 8 grams of protein. It's going to be closer to half of that, or even less than half, 120 grams of protein. Often people will talk to me about the vegetables that are good plant protein sources. And although they're not listed on here, I do want to say generally 1/2 cup of something like broccoli, you'll get 1 gram of protein, and 1 cup of kale, you'll also get 1 gram of protein. So I encourage you to include those, but they're not going to be significant contributors to your protein needs for most people. So let's move on and talk about our carbohydrates. And briefly, we want to choose carbohydrates that are higher in fiber, and some good carbohydrate sources I like to think about are artichoke and squash, split peas, beans and lentils that you saw on the other side, as well as our seeds. Our fruits can be a fiber source like raspberries and blueberries, and apples, pears. And we want to choose those foods to help our fiber needs, and we want to choose those fruits to help sweeten our meals as opposed to relying on refined carbohydrates. But that doesn't mean you have to stay completely away and not have any sort of added sugar for taste pleasure. We do want to say that thinking about your total calories, if you were to limit it, you want to limit your added sugar intake to less than 10,000, or I apologize, to less than 10% of your total calories. For somebody that had a 2,000 calorie diet, that translates into 50 grams of added sugar. And that's about 12 teaspoons of sugar. So although I don't think you need to hit that goal, we do think that's more of a max. If you did include a teaspoon of a sweetener in tea, or you wanted to bake something, I want you to feel free to do that without being fearful of the changes, any sort of metabolic changes in your body. So with that, let's go ahead and focus on our healthy fats. And we do know that this discussion with healthy fats, recent research shows that there's a more complex picture of fat intake and health. But in general, we want to choose more often our unsaturated fat, limiting and trying to avoid the saturated fats and more of the trans fats. For those that are concerned about their oil intake, we want to choose foods or oils respective to how we're going to prepare it. So something that is going to be used in high heat application, you want to use something with a high smoke point. And I will recommend things like avocado oil or a refined olive oil. The unrefined olive oil has a lower smoke point, and so you would use it more as salad dressings or something that doesn't take high heat. And I want to go ahead and briefly discuss our healthful diet and thinking about sodium intake. The average American will consume more than 3,500 milligrams of sodium. A lot of it's going to come from our breads, our condiments, and our canned and processed foods. And for most individuals, the goal is to keep to 1 teaspoon of salt. This slide will list some recommendations about how to do that. But I also see the reverse happening for individuals. They get really tight with their food choices and restrict all sources of sodium. And maybe that's being overly cautious, and their sodium intake should actually be a little bit higher. This next slide is something that people like to take a look at in terms of our hydration needs and our fluid needs. And with that discussion, I talk about trying to choose drinks that have less added sugar, and pay attention to, if you do consume alcoholic beverages, to limit your exposure to the alcohol content and pay attention to the specific content. For women, your recommended consumption is 1 serving a day. For men, the recommendation is 2 servings a day. In our next slides, I do want to spend more of my time on talking about some symptom management. And we heard from Dr. Oppenheim earlier today and Dr. King yesterday about some of the symptoms that people can experience with treatment, and especially if someone is having to undergo chemotherapy like doxorubicin or ifosfamide, nausea can become an important factor that affects their ability to eat, affects what they can eat and how much they can eat, and can negatively contribute to the fatigue. So Dr. Oppenheim started his talk by discussing antiemetics, and I only want to add to his discussion by saying that we want you to use your antiemetics prophylactically, or when you have the first hint of your nausea not being controlled. This isn't nausea right before you feel like you're going to throw up, because if you wait that long, you're not going to be able to properly address that side effect. We want you to think of your anti-nausea medications appropriate if at the beginning of the day you feel a little queasy or your stomach turns at the smell of foods, that's an appropriate time to start using your anti-nausea medications so that you can get food into your stomach. And we do know that apart from medication management, trying to avoid an empty stomach is one really important way to help manage your nausea. Trying to eat simple foods that are easy to digest, or at least starting your meal with bread or crackers or toast, or some pasta or potatoes is a great way to settle the stomach. And also to stay hydrated, taking sips of water or broth or herbal tea throughout the day. The more hydrated you are, the less likely you'll feel nauseous. And we do know that the stomach is your second brain. So if you're feeling tense, if you're anticipating nausea, if you're anticipating throwing up, you want to do a physical review of the body. Think about what's going on. Where are you holding your tension? Are your shoulders up to your ears? Are you not taking full deep breaths? And take that moment before you try to eat to relax the body physically so that you can tolerate more food when maybe you're dealing with a little bit of nausea. Also good to consider is having little candies handy. Sometimes taste is something that is not appealing during treatment, and having some candy to kind of wash out your taste or give you some other flavor or a source of ginger, lemon, or peppermint can be a great way to help keep nausea at bay. Other things to think about would be to avoid foods that are spicy, fried, or greasy, avoiding foods with strong odors, maybe choosing foods that are cool or warm instead of being too hot or extreme in terms of cold. To continue that discussion, if someone is having emesis, we want you to try and clear the mouth, choose dry, low-fat, and bland foods, maybe sometimes having a little bit of bowel rest, but not going too long without eating or drinking is appropriate. Let's go ahead and also discuss poor appetite. And we do know that your desire, your hunger levels may fluctuate during treatment, but I always want to speak to the fact that eating is part of your care, and that sometimes you need to focus on eating for your body's nutritional needs versus eating purely for taste or pleasure. We want to think that it is part of your treatment, and that trying to eat on a schedule, regardless of your hunger level, may benefit you in going through treatment. Of course, there are ways to try and stimulate your appetite, and we want you to choose foods that are more calorically dense. So maybe choosing more of the healthy fats and the carbs are going to be better to get your calories versus trying to have more vegetables is what is more important at this moment. Hopefully you can go ahead and review that at your leisure when you have more time. I do also want to spend a couple of slides on weight management. When we think about weight management, this is something that I, as a dietitian, or my colleagues, we can spend a lot of time, more time than what we have today, to talk about our goals and how to achieve those goals. What I do want to say is that for individuals, you don't want to do everything on this list. You maybe want to pick a few goals, and you want to think of SMART goals in terms of food choices and portion control. You want it to be measurable, achievable, meaningful to you, and timely, and you want to make time for eating. You want to have a plan about what you eat so that when it's game time and you're hungry, or maybe you haven't eaten for a long time, you want to know what will make your body feel best and what choices you can turn to versus going to what is the easiest, most quickly accessible. I will pull up the next slide and talk about when you're not able to prepare your own meals, part of healthful eating, part of having eating be part of your health plan is to look at your food choices, to acknowledge how food fits into your life, and also consider that we want to make educated choices. So sometimes looking at your meal, the restaurant menu ahead of time can benefit us versus just going with the flow or not preparing beforehand. I know I sped through everything and I saw some chats pop up, but I was not able to take a look at that. So I hope I did not take time too much. I will stop sharing here because I do know that Dr. Asher will talk about more of this.
We have a
Great, thanks.
That was great. We have a couple of questions, and I think you covered a lot in your talk of some of the questions. Let's see. When a patient's going through treatment, especially chemo, and is reluctant to eat often in main meals, what recommendations do you have for the primary caregivers to handle the nutrition?
That's really a great question because we do know and we rely on our patient support system to try and encourage people to eat. But I want to always send home the message that we ask that you be the help to make it easier for people to eat, meaning that we have good food choices and variety, but it's always up to the individual how much they're going to eat and if they can eat. So please try to encourage people often, but know that they're the ones that are in their body understanding how they feel, things to help people eat when they don't feel like it is to have food available all the time. So have snacks or ready to go finger foods available to help. Maybe if they can't have a meal, they can have a snack, or if they can't have a full snack, at least they can have a bite of something or a spoonful of something and have that be something that's nutrient dense. So it could be peanut butter on crackers, it could be yogurt, it could be some soup that you blend. We want it to be easily accessible, and we want to have food give the most calories and protein or whatever specific nutrient they're concerned with.
Okay, that's very helpful. And things like Gatorade are supposed to help replenish stuff from dehydration, but it's so sugary. Are there more natural / homemade solutions to get electrolytes back into the body?
So I definitely will call people's attention to having broth. Broth can have good electrolytes, coconut water with no sugar added. I say watermelon juice, it can also be a good source for electrolytes and help stay hydrated. As someone also put here on the chat, there are some good commercial options for protein juices and shakes. Ensure is definitely one of them. Boost has another one. And there are oftentimes even more choices that you can find on the grocery store. And if you just take a look at the label, you can see what may be lower, a better choice in terms of added sugar.
Then I think there were two questions about, and I think I did see that slide and you did go over it, but maybe a little bit, any recommendations on protein supplements for vegetarians, vegans? What about like bone broth and stuff?
Yes, so you bring up a good point. There are commercially available protein supplements that are plant-based, and some of the ones that come to mind would be Orgain or Kate Farms. Those are protein shakes that are available. Also, there are some good over-the-counter protein powders that are plant-based, maybe pea protein-based, and It just takes going to the grocery store or through checking a website to see if there are ones that are appropriate for you. I do give a caveat that sometimes if your body's not used to a pea protein powder or shake, it can be more gas producing. So you want to maybe start with a lower amount and build up to it to see how your body tolerates it. But there are a lot of options. And also when we think about foods, nuts and seeds for proteins, it can be really easy to make your own smoothie and then add in some spirulina or add in chia or flaxseed to help provide some of that protein.
Okay, and then how does this advice change with managing diabetes or other conditions?
We do know that a cancer diagnosis does not happen in isolation. And so hopefully you get to work with somebody that can take a look at your medical condition and make appropriate recommendations. Often, depending on diabetes, if you are more diet controlled, limiting your carbohydrates, choosing even less added sugars, that very nicely aligns with a health promoting, cancer protecting diet. But we do know there are different ones, say renal disease, where there are more restrictions depending on what stage you're at. And that's when I really encourage you to discuss your needs and your goals with a nutrition professional. And hopefully there's a dietitian on your site at Cedars-Sinai. There are 8 of us that are oncology certified dietitians that work with your treatment team to know specifically what your goals and your needs are to make choices appropriate in the moment.
Diana, thank you so much for joining us today and all the great questions. Thank you guys.
They're great questions. Thank you.
And I think we're going to move on to Dr. Asher. Bear with me, I will.
Good. So Dr. Arash Asher is our last, will be delivering the last topic of the conference. He is the Director of Wellness, Resilience, and Survivorship, and Associate Clinical Professor of Medicine with the Patient and Family Support at Cedars-Sinai. And welcome, Dr. Asher. We're so excited to have you present today.
Thank you so much. Do you hear me okay? Is my audio working?
Yeah, that's perfect.
Okay. I know I have my slides here, but just give me one moment to bring it up, please. Okay, hopefully that's working. So I really appreciate the opportunity. I was just thinking to myself that it's probably a little bit ironic or appropriate maybe that we're going to talk about resiliency at the very end of this conference. So thank you for hanging in there. So I am a cancer rehabilitation physician by training, but one of the areas over the time I practiced that I realized was very important from in terms of rehabilitation and wellness from a holistic perspective was really thinking about strategies to optimize resiliency and manage distress. At Cedars, we usually spend we have a program where we have 12 hours over 6 weeks where we dive into this. I'm going to try to highlight some of the most important themes in just about 15 to 20 minutes. So this will kind of be like a tapas like experience. But I think the questions that I think all of us encounter, whether we're going through sarcoma or another cancer diagnosis, or even stepping back and thinking about what we're all enduring with the pandemic and other circumstances in our environment today, are these basic fundamental questions that you see before you, such as what does it mean to be healthy or whole and resilient? And in my mind, there is not a simple medical solution for these things. So I and others in our team, as I imagine your own physicians, use things like antidepressants or anti-anxiety drugs, and I think they're great tools to have when appropriate. But in and of itself, I do not believe that Ativan or Xanax or Prozac, in and of itself, really answers the question of what does it mean to be resilient. And I think one of the challenges when we think about health in a medical system, and you can challenge me, and hopefully we'll have a couple minutes in the Q&A to talk about this, but if we think about how we define health in the medical system today, I could imagine many of you might be saying, well, you know, if my scan comes back and everything's clear, you know, I define myself as healthy. And if it shows something that I wasn't hoping for, then I may not be healthy. And the challenge with that, I believe, is that then we're always in a state of reaction. So, right, we have no control over what that tumor marker or that scan or that biopsy is going to show. So I think the challenge is if we're going to think about health and resiliency in a more comprehensive way, we have to find other strategies. And so these are some of the themes I'm going to be talking about. I'm just going to jump right in, and I'm going to propose that one of the important ideas to consider is thinking about one sense of meaning or one sense of purpose, and thinking about what this may have to do with the concept of resiliency. I want to start with just an anecdote. And again, I know this is an anecdote, but I think it's a very compelling one. And you may have heard of this story from a few years ago. This is the story of Mr. Israel Crystal, who in March of 2016 gained a certain amount of fame because he had the Guinness record for being the oldest male alive in the world at that time. He was 112. He actually passed away 1 month before his 114th birthday. And when I first heard the story, and maybe you had the same impression, I just assumed, you know, if somebody lived to 113 or 112 years old, I just assumed he had this very kind of idyllic life where, you know, maybe he was a shepherd in Italy, and you know, he had no stress and no major traumas, and you know, he had, you know, lots of support and whatnot. But we couldn't really be farther from the truth. He actually was a Holocaust survivor. He lost both of his children. He lost his wife. He whittled down to 82 pounds by the time he left the concentration camps. And I'm not here to retell the horrors of the concentration camps, but I think we're all basically familiar with all that one goes through. Now, when he got this Guinness record, you know, he was kind of subjected to all these interviews. And of course, everyone asked him this one question, right? How did he make it to 112? And I just pulled out one passage that at least resonated to me. I have no idea how he made it this long, but this is one thing that he said. I don't know the secret for long life. I believe that everything is determined from above, and we shall never know the reasons why. There have been smarter, stronger, and better looking men than me who are no longer alive. All that is left for us to do is to keep on working as hard as we can and rebuild what is lost. Now, again, I have no idea how he made it to 113, but if I had to at least make some educated guesses, I believe that that last sentence may have had something to do with his resiliency, and that sentiment he expressed, that we have to rebuild and work and create something that's important to us, I imagine was his sense of meaning and purpose, which was very clear in his life, and how he chose to rebuild and work towards something in the future. And this idea has been expressed by others, including Dr. Viktor Frankl. Many of you may be familiar with his work called Man's Search for Meaning. And he also was a Holocaust survivor. And he wrote this important book called Man's Search for Meaning. And his basic tenet was, and there was a lot of beautiful ideas that came out of his work, Man's Search for Meaning. So if you have a chance to read it, I hope you do. But one of the things he said is that one can rise above any challenge or rise above our suffering if we can find meaning in what we're going through. And he basically described 3 fundamental sources of meaning. that one can find, whether it's one of them or two of them or all three of them or some combination thereof. And he argued that either it's through our work, and that means doing something that is significant, or it means through love. And this, I imagine, meaning love for another person or for the community or your family, your tribe, etc. Or through the idea of developing some sense of courage and bravery, particularly during difficult times. And I know these are very kind of profound concepts, but he really encouraged individuals to think about these three areas. And his argument was that nobody can take away how we respond to a situation. I'm going to come back to that in a second. So he really argued, and this is one of his famous quotes. He said, "When we are no longer able to change a situation, we are challenged to change ourselves." And I think what follows from this kind of sentiment is what I was kind of alluding to earlier, that we have no control over what the scan or the biopsy is going to show. But his argument was we could always control. Nobody can take away how you respond. He argued that the Nazis could not take away your inner sense of dignity and your inner sense of, again, who you are and what's important to you. So keep in mind, Frankel's book, Man's Search for Meaning, came out in the early 1950s, I believe, after World War II and the concentration camps. I could only imagine how he would feel. And I'm going to go back to this if you were alive today. Now, remember, if you've read Man's Search for Meaning, one of the things that Frankl talked about is he had this observation that, maybe anecdotally and from his experience and kind of astute observation, that maybe, let's say, 1 in 10 people survived. And he was the first to agree that, part of that was just luck. But his argument was that it was more than just luck that seemed to be a common thread among this 1 in 10. And his belief was, and his observation was, that 1 in 10, again, seemed to have a profound sense of meaning and purpose in what they were going through. And he felt that that was a part of their resiliency. And that's why they were less likely, he argued, to succumb to hunger, to starvation, to all the infectious diseases that spread through the concentration camps. Now, that was his observation, and you have to wonder what he would feel if he were alive today to see more recent research that have kind of looked at this matter. And this was a study that came out a couple of years ago that kind of grouped together 10 smaller studies and looked at over 100,000 individuals. And what they were basically able to do in this study was to look at all the things that we already know relate to how long one lives. So we know who was smoking in the study and who was obese and who had high blood pressure and who had high cholesterol and all the things that are known about. But they also, factoring in all those variables that are known, they compared the individuals who had the strongest sense of meaning and purpose to those who had the least. And when you factored that all in, they were able to show in the study that all-cause mortality was reduced by 17%. And similar for cardiovascular events, which basically means your chance of having a heart attack or stroke was also reduced by 17% if you had a higher sense of meaning and purpose compared to the lowest. And again, in a way, you can imagine this was what Frankl was arguing all these years ago, that the sense of meaning and purpose seemed to confer some, not just psychological, but maybe biological protection. The second concept that I think is so difficult with how we're inundated with images and ideas and whatnot through the internet and social media and cable TV and whatnot, and is learning to try to manage some balanced sense of perspective. And this is not easy, especially when we maybe feel lost in the medical system and going through medical challenges to kind of regain some balance. I'm not going to talk about this right now in any detail. I imagine, unless you've been under a rock, we've all heard of this idea of mindfulness. But I am going to just spend a second on this because I think it's really important to remember that it's really hard to have some sense of perspective unless we have some time dedicated to introspection and self-awareness. And I think that's really what mindfulness may offer us. And again, this takes practice, doesn't come overnight. But the reason why this idea has gained so much attention, not only in the general medical literature, but also in the cancer wellness and survivorship literature, is that if we create some stop times and allow ourselves to take control over differentiating again what we're feeling and what we're thinking and what reality may be, and really focus in on the present moment, that this may be one important step in the art of mastering perspective. So if you haven't practiced some kind of mindfulness program, it really might be worth considering, particularly today. One of the interventions that's gained a lot of attention in the medical world is something called mindfulness-based stress reduction, or MBSR. So just an idea to consider. But Frankl, again, also talked about the importance of managing perspective. And he talked about this in the concentration camps. And again, you could imagine you're in this prison with lack of food and hard labor and poor sleep and terrible conditions. And his argument was you had to manage perspective. And this is one of the things he said. And again, much easier said than done, but please reflect on this. He said, "We who lived in concentration camps can remember the men who walked through the huts, comforting others, giving away their last piece of bread. They may have been few in number, but they offer sufficient proof that everything can be taken from a man but one thing, the last of the human freedoms, to choose one's attitude in any given set of circumstances, to choose one's own way." So his argument again was the Nazis could not take away this freedom. And by extension, if he were sitting with us in this group, in this setting today, I know he would argue that cancer cannot take away this last freedom of how we're going to respond, of our human dignity and our morality. And again, this is hard because we're getting bombarded with, lab results and test results and medical pieces, and we respond. And again, this is why mindfulness is important, to kind of create this gap. And there's this quote I love that speaks to this, and it says, "Between stimulus and response, there is a space. In that space is our power to choose our response. And in our response lies our growth and our freedom." Again, much easier said than done, but with practice, as Viktor Frankl and others have shown, that this is something that is viable. Now, to round out this piece, I want to just spend a minute thinking about a concept that I learned about a number of years ago. So you see a couple of words on the top of your slide. It says hedonic versus eudaimonic. Now, I think all of us generally know what is hedonistic type personality, right? And when we think of someone who's hedonistic, generally we think of pleasure seekers. So if I was at a cocktail party and I knew the person to my left is a hedonistic type personality, I might assume they're there because they knew that there was going to be, filet mignon and champagne and dancing and lights and all the nice things in life. And so they were drawn to that. So they came to this event. Now, if I were to tell you the person sitting to my right was a more eudaimonic person, what does that mean? And eudaimonia is a term, I think, originally that stemmed from Aristotle. And this is an idea where eudaimonia refers to someone who's generally more altruistic, who's more virtuous, who's thinking about service and community building and things generally that are meaningful. Now, what I found incredibly fascinating, and I know this is a lot of gibberish, and I'll walk you through this slide in a moment. There was this study recently that that looked at adults who all said that they were well. So they had high levels of well-being. In other words, they said that they were generally happy. Okay. And even though they were all happy based on these questionnaires, they decided to look at their inner biology. And what they did is they compared people who were at the extreme. So they're either happy and very strongly hedonistic, or happy or very strongly eudaimonic. And I'm just going to focus on part B of the graph for simplicity. And what they basically found is that the hedonistic group, as you can see here, had higher levels of inflammatory compounds. And as I think many of us may be aware, inflammation is associated with many of our chronic health problems like heart disease and maybe some types of dementia, maybe some types of cancer like breast and colon cancer. And they had lower levels of antibodies. And again, antibodies is critical for our immune function. It's part of our immune system. And the opposite was seen in the eudaimonic group. They had lower levels of inflammation, and you could see higher levels of antibodies. And again, it's hard to know, but this is what Frankl argued all those years ago, was that it seemed that the people who had a sense of meaning and purpose, which may be another way of describing a eudaimonic type personality, seemed to be less likely to succumb from infections in the concentration camps or all the other traumas that would go on there. So this is all conjecture again, but again, I could only imagine how satisfying it would have been for someone like Frankl to see some of the more recent cutting edge biological research that is really showing that we can change our inner biology in a way that really may make a difference, just based on how we live our life. And we know there have been other studies later that have shown that you can go from a more hedonistic kind of perspective and lifestyle to one of eudaimonia, of meaning, of purpose, of service, of community, that then in a matter of just 6 to 8 weeks can change these compounds such as antibodies and inflammatory cytokines. And one of Frankl's most important challenges that he wrote about is, and I know this is sometimes difficult to think about, is he argued that rather than going around life and saying, what do I expect from life? His argument was that you should ask yourself, what does life expect from me? And I know it might take some time to wrestle with these kind of questions, and some might choose to switch the word from life to, let's say, God or creator or nature, or however you want to frame this. But when one goes from what do I expect from life, it's very easy to be disappointed with what's going on around the world around us. With nobody wants to have sarcoma or any kind of cancer or any kind of medical illness. But when we reframe that to a question of what does life expect from me, it may be another vehicle to change our perspective, to remind us the things that we still have control over, and to try to focus on those arenas as much as possible. I realize I'm short on time, so I'm just going to conclude. There's many other dimensions to resiliency that I think are really important. And maybe we could revisit this topic another day. But I realize these concepts that we've been talking about, whether it's mindfulness or mastering perspective or thinking about eudaimonia versus hedonism, all this takes practice to change how we view the world. And so I really love this quote that I'll conclude on, and maybe we'll have a minute or two for questions. And the quote is the following: "As a single footstep will not make a path on the earth, so a single thought will not make a pathway in the mind. To make a deep physical path, we must walk and walk again. To make a deep mental path, we must think again and again the kinds of thoughts we wish to have dominate our lives." I thank you all for your attention and for the opportunity. And if our facilitators can give us a couple minutes for questions, I'd be delighted to take them. Thank you very much.
So I think, I mean, that was an excellent talk. I mean, very helpful. I think we had just more comments. Everyone was like, this is great. Our thoughts can definitely help our health. The cells are listening. And then another chat. I love this section, I believe, as Dr. Asher does. So it's been, really helpful. I don't know if anybody else has any particular questions. I think we're all still thinking.
I will just mention that we did develop a program with my colleague Jeffrey Wertheimer at Cedars called the GRACE program, which stands for Growing Resilience and Courage. And we go through these concepts and many others that unfortunately there was just not enough time for over 12 hours. So if there are individuals that might be interested or feel like they might benefit from the full 6-week program, you're welcome to email me. I can leave my email in the chat if it's not in the system, because we're running them virtually. So, I always don't know how much capacity we have, but I think we're trying to run this more since, I'll send it to the whole group, sorry, in case anyone's interested. But I appreciate the comments. Thank you.
Okay, so he just put that in the chat, his email. Thank you.
Share that with all the attendees, Dr. Ash.
Yeah. I think it went to, that was all to the panelists.
I think it went
Maybe
to all panelists, so we can put it in the, I can put it in the, oh, you got it?
Oh,
Okay,
yeah. Okay, good. Okay,
thanks, Alyssa.
Yeah. Okay.
Okay, thank you.
Perfect.
Great talk. And if there is any messaging around volunteering for the Sarcoma Alliance, I think that was a great segue.
Thanks so much, Dr. Asher.
It makes a difference. I appreciate it. Thank you so much.
Thank you very much.
There was
Alyssa, I think we're over to you.
Right. So we're just going to wrap up today with some housekeeping items. Let's see. I hope everybody really enjoyed the sessions. We do this for you all, so I really want to make sure that folks know about the Sarcoma Alliance, that we are here for you, and that we are so appreciative of all of the physician speakers, all the speakers, all the volunteers who really dedicated a lot of time, energy, resources to put this together for you all, to make sure that you have the guidance, support, and education that you really need. So thanks again for the sponsors. Special thanks to Dr. Gina Diamato. She did a great job helping moderate and respond to a lot of the questions. Thank you so much to the work group who has worked on this the entire year to bring this to life. So thank you to Suzanne Schwartz, who is our leader, fearless leader on that. And thanks again to all of our sponsors. Did I leave anybody out? If I did, I apologize, but thank you, thank you, thank you. Charles and Joseph, of course, they also are amazing event planners. So thank you, Charles and Joseph, for helping to life. So I just wanted to, to Dr. Asher's point about volunteering, there are lots of opportunities. We don't want you to go away from this conference with no next steps, right? And opportunities to really continue with the Sarcoma Alliance. So I just wanted to bring up a slide. You can certainly challenge yourself and friends to fundraise and donate for programs. You can raise awareness by sharing our nationwide PSAs, which are launching November 1st through January 31st. You can decorate your home, your workplace, school, city with signs sunflowers or lights, we actually have some downloadable signs on our website. You can volunteer. You can serve as a volunteer, speaker, or committee member. You can participate in our webinars, the next Sarcoma Exchange, which is going to be held July 16th through the 18th in 2021, hopefully in California. But we will, monitor what's happening to make sure everybody stays safe. You can also wear yellow outfits, shoes, makeup, or purchase Sarcoma Alliance merchandise. Earlier in the day, I had shared the branded masks, which are available for pre-order. And then just a couple of housekeeping items. We want to make sure that you complete your survey. We really appreciate all of the feedback and messages. We really do take those into consideration when we're preparing for the next conference. Every attendee is going to receive a link to our eval following the conference, so please make sure to complete that. Everyone who completes the survey will also have an opportunity to win the iPad and other prizes. For extra chances to win, you can always donate $25 each for an extra chance to win some of the prizes. And then finally, the presentations will all be archived. We will have the videos on our YouTube channel. We'll also have, of course, the Facebook live stream available as well. And then the actual presentations, the PowerPoint presentations, will be uploaded on our website as well if you'd like to reference those. So thank you, thank you, thank you. Please feel free to reach out to us anytime. Here's our information, email, phone, website, and thank you again. Hope you all have a good rest of your weekend.